All right, guys, good morning. I think we have everyone registered and everyone has taken the pre-test as well. So we're going to go ahead and get started and try to stay on track today as well. So for those of you who don't know me, my name is Rmaah. I'm a Global EM Fellow at Penn. Very excited to be running the VEC committee this year at GEMA. And so we're going to go ahead and get started. So you guys have all received the BEC workbook and also the facilitator handbook as well in the last couple of weeks, and should have had an opportunity to kind of go over it and look at what the BEC course does. But just for everyone to be aware of, it was really designed for frontline, pre-hospital, and facility-based healthcare providers to who provide care for adults and children coming for a variety of urgent and emergent care as well. And so it was really meant to be a simplified way to kind of teach these healthcare providers to provide emergency care. And really designed to provide a basic initial approach to the acutely ill or injured child or adult as well. And similarly, it was designed to kind of help these areas and help train the frontline healthcare workers in these areas to deliver a timely and appropriate care for the local population that they're serving. And so a little bit of background about the BEC course. It was developed after a consensus process through over 40 countries, and it took 4 years to come up with this course. It was co-developed by the WHO and the ICRC, and it's endorsed by IFEM. It was initially piloted in 3 countries, and since then has kind of gone everywhere in the world in terms of kind of being put in place. And a few thousand people at least have been trained to date with the BEC course. It's really important to note that every aspect of this course came from thoughtful evaluation and consideration, really to be applicable to any setting in the world and be culturally cognizant and aware as well of different settings. So the course aims of the BC and the TOT, which you guys, of course, will be taking today, is to ensure that all participants of the course of the BEC are able to use the ABCDE approach to assess the emergency patient, and for you guys in the TOT to teach that approach to participants, to ensure that participants are able to identify and provide evaluation and interventions for life-threatening conditions, and to ensure that participants understand when to call for help and when to refer a patient for a higher level of care or management. So who should be the participants here? It's really meant to be for the entire emergency care team. So it's not necessarily just for physicians. It can be for nurses, paramedics, any health officers, any healthcare provider who provides any intervention or delivers any emergency care to a patient is okay to take this course. It's really, really important to understand and important that the team understands the same basic emergency care concepts, which goes into my next point of where this course will be used. Very important that you are aware of the participants that you are teaching and kind of guiding your BEC teaching to the participants in the audience. So if you have an audience full of physicians, you may use a little bit more medical jargon, versus if you have a mixed group of nurses, paramedics, and physicians, you may have to change how you are teaching the course itself. And again, utilized across various different settings, pre-hospital and in the actual hospital as well. And so I know that everyone, it's kind of been hammered to you guys over the last several months with emails and also the last several weeks as well with emails in terms of what the process is to become a facilitator and how you can teach a BEC. So you're gonna see this diagram later on as well, and we will also be emailing this to you guys as well after this course so that everyone is on the same page. Since every year, this is the 4th year we're doing this, and every single year we have confusion about what the process is. So the first step is to take the BEC course. You guys are skipping that step right now, but you still have to do it. Doesn't mean that you get like a automatic BEC done. You still have to take the BEC itself. The BEC course itself is approximately at least 4 to 5 days, but it can be even weeks long asynchronously done as well. Once you do the BEC course, you are a BEC trained provider. After that, you take the TOT. So you guys are taking the TOT today. This is unusual. What you do is once you are a facilitator, you identify people in the BEC who are going to be good for teaching the next kind of cohort, and you select them for the TOT. The TOT is 1 to 2 days. Today it'll be, of course, 1 day. Once you take the TOT and the BEC, you become a provisional facilitator. You have to teach the BEC under a master trainer when you are a provisional trainer. Once you have done that, you become a registered facilitator, which means that you can teach BEC courses independently at that time. It's still like people still prefer to teach it with a master trainer at this point since there's so much to learn from master trainers, but technically you are allowed to teach a BEC by yourself as a registered facilitator. Once you teach 2 additional BEC courses, so now you've taught 3 courses, including the one that you taught under a master trainer, you become a master trainer. And once you become a master trainer, you can conduct BECs and TOTs. So you cannot connect a TOT until you become a master trainer. That's a lot, I know. So just for you guys to be aware, again, in this room, you're taking the TOT today. You all still have to take a BEC. This year, the BEC committee, we made a database for everyone who is registered as a participant or trying to become a facilitator or is a facilitator. And we also have a WhatsApp group for communication for both courses for people hoping to continue to become a facilitator or for teaching purposes. And so after this course, I will be emailing you guys out with the link to the actual database, like sign up, and then also for the actual the WhatsApp that we have kind of created as well. Does anyone have any questions about this process? It's okay if not. You can always email me later or text me as well. Okay, if not, we're gonna keep going then. And Alicia, you are next.
Good morning, everyone. And, oh, that's so sad. Good morning. Let's try that again. Wow, I know it's very early on this very gray day in Philadelphia, but if you haven't been to Philadelphia before, this is one of the best cities in the United States. I did my residency here. There's so much amazing food. There's this whole BYO culture. So if you like to BYO whatever you want, you can bring it to a restaurant. It's such a fantastic place to be. So I'm excited for you all to eat and eat well. So my name is Alicia Janiska. I am a pediatric emergency medicine provider. I am from Brown University in Providence, Rhode Island, and I'm going to be walking you guys through the course structure today. I'm also a master trainer for basic emergency care. I hope you have a great time with this course. I wanted to ask how many of you actually did the Penn course this week? Oh, great. All right. Fantastic. So for you guys, this will be old hat, but so let's just dive right into course structure. So there are 5 major topics that are covered by the BEC. The first module is learning about what are the life-threatening conditions, and we do the ABCD approach. Anyone know what the ABCD approach is? Don't be scared. I'm just trying to get you warmed up for this morning. A is, B is, C, D, E. Very good. All right. So that is all what you'll be learning in that first module and reviewing. The second, third, and fourth modules, third, fourth, and fifth modules include altered mental status, shock, and difficulty in breathing. But the overlay of all of this is trauma. So there is a separate trauma module, which is our second module, and it covers a lot of these topics within the trauma module because trauma can cause any of these things. So for the BEC course, when you're actually taking it and when you're actually teaching it, there are several parts of it. It's supposed to be, people learn through many different ways, either sitting in lectures, being more participatory and interactive, doing small groups, many different ways to do it. So lectures are the mainstay of this course. The lectures are available online from the World Health Organization website, and they are meant to be interactive and participatory. When we practice our lectures today, you'll get a lot more feedback about it. I don't know if any of you have had the opportunity to actually look at the lecture materials yet. Has anyone seen these lectures? I see your eyes doing this, so I feel like maybe you have. Oh, okay, great. So with these lectures, when you look at them for the first time, don't be scared. There is a lot of heavy and dense material in it. The slides are very packed, but that doesn't mean that you can't make it interactive. It's all about the energy that you're bringing to the lectures, because otherwise you can make it really, really, really dull. But again, for those lectures, you really want to try to make them interactive and participatory. I highly encourage you to take a look at them on the World Health Organization website. There are also case scenarios. These basically you break up your learning group into smaller groups to run through different cases based on either the ABCD approach, trauma, difficulty in breathing, those 5 modules as I mentioned before. Skills station. I cannot say enough how important these skills stations are. Again, you'll be breaking out into small groups with your learners to provide them with hands-on practice. This is your time to, I feel, really, really shine, because this is the part that really I feel matters the most. People can read the lectures on their own or listen to the lectures, listen to the case scenarios, go through them, but actually being able to do the skills is incredibly important. So skill stations are in the back of the BEC workbook for your participants. And then there are interactive large group discussions specifically on medications and handover and transfer, and I'll get into that in just a moment. And generally, the basic emergency care course is done over a 5-day period of time. There are several instances of people doing it in 4 days. So, for example, in Belize, we did it in 4 days. You guys at Penn did it in 4 days. Lots of people do it in 4 days. It just depends on your learner group. All right, essential content. I walked you through the basic structure that you'll need to go through, but this is very important. There is a separate section based on the medications, essential medications that people should know when doing emergency care. When you look at that material in the actual book, it's pretty dry. So some lovely people came up with the idea of making it a medication Jeopardy. It's just as you imagine Jeopardy would be without Alex Trebek. Basically, you can break out into teams and play Jeopardy to get the information about medication. Why is this important? Lots of different places will tell you that they don't have specific sorts of medications. And the one that comes up the most is naloxone. Anytime that I bring this up in a different area, they're like, we don't have people who are using opioids, but this is a global world. People travel and people might bring their stuff with them. So it's important to know that. But this medication Jeopardy gives you the opportunity to be able to help others understand what the different medications or essential medications that are needed. It also gives them an opportunity to talk about what they do have, and if they don't have certain things, what medications can they use instead. The other very, very important one is the handover lecture. This is just a small blurb in the back of the book, but this lecture is incredibly important. This is where we teach our participants about how to do an appropriate handover when transferring to another facility. And this is using the SBAR methodology. For a lot of people, it'll be the first time that they're doing it. If you're working with EMS personnel in different countries, they might have their own different way of providing handover to hospitals, but this is just a unifying way for us to be able to provide handover. All right, so the participant workbook, if you haven't had the opportunity to look at already, please make sure that you do. It's broken up very easily. Each module starts off with key terms. The key terms are basically just a word, so it'll say, retractions. There's a glossary at the end of the book that participant can go to fill in that definition. Each workbook, as you go along, will have workbook questions. The workbooks go along with the lecture material, so if the participant hasn't had the opportunity to answer the workbook question on their own before coming to lecture, during the lecture, there's a point where you can pause and then you can fill out that workbook question at the time. Case scenarios I've already mentioned, those will be breakout sessions. And at the end of every single module, there are multiple choice questions meant to go through with the group. Every single participant will need to go through every single part of the skill stations. Again, if you haven't looked at the BEC participant manual, please make sure that you do. There is a long list of skills, and sometimes it's just as simple as assessing scene safety. People are actually very good at this. I feel like every time that we put it into their heads once that you need to assess the scene, every single time you are talking about anything, they'll say, did someone assess the scene? Is the scene safe? Did I put on my PPE? Which is really great. But that is part of what everyone will need to say when they're doing their skills assessment. And then you'll go into things like, putting a 3-sided dressing on, how to appropriately bag mass ventilate a patient, things like that. Also, as part of the tools that can be used are these things that are called quick cards. The quick cards essentially give the bullet point information about each of the modules. This is just a quick overview of how the chapters are structured. Again, I ask you to take a moment and opportunity to look through your guides, through your participant guides so that you can see how it's all set up. As I mentioned before, at the beginning of each module, you'll have some key terms that need to be defined, and the answers to those key terms are in the glossary at the end of the book. This is a picture of the glossary. These are the workbook questions, which are scattered throughout each of the modules. And again, there's two case-based scenarios at the end of the module. One is an adult case and one will be a pediatric case. And then the multiple choice questions. All of these have to be completed in order for a participant to say they have passed the course. This is one of the requirements. For the skill stations are all at the end of the book. What I thought was really wonderful in our last BEC that we just did in Jamaica was having the skill stations printed separately, so participants or even the facilitators can have their skill stations sessions all together, not have to flip through to try to figure out where they are in the book. And these are just examples of the quick cards that can be printed out. All right. So in order for a person to say that they've passed the course, complete the course, they must do a pretest beforehand. And that has to be, well, this being completed to receive the participant manual is a little bit challenging because sometimes in an ideal world, the pretest gets sent out before and then the participant manual gets sent out. That practically doesn't happen in my experience. Usually it's happening on the same day. Again, recommended 1 week prior to the course. Recommended, doesn't always happen. They have to attend all the sessions. So if participants know beforehand that they cannot attend sessions, that means they are not able to actually complete the course. Depending on the timing of the course, facilitators might be able to help them see them out with sessions afterwards. You have to use a sign-in sheet for both the morning and the afternoon sessions every day. And again, the workbook sections must all be completed. All skill tests must be passed. You get checked off when you do your skill tests. And then those case scenarios, as I mentioned before, each participant has to run their own, meaning that from the very beginning, scene safety, going through the ABCD approach, run through an entire case scenario to be able to complete the course. And then they have to pass the final written exam with a score of 75% or greater. This is just an example of a schedule, a 5-day schedule. Again, all this material will be available to you, and that is it. Oh, sorry. Yes, I said this all before. Yes, important. Documentation. When you are a facilitator running this course, there's a lot of paperwork that you have to be in charge of. So making sure that you have the participant's name, including how they want it to be written on their diplomas, very important, because somebody might have a nickname that everyone calls them, but that is not their name that their parents gave them, and that's what they want on their diploma. They have to complete their task for the BEC. You have to keep track of whether that person passed or failed the course. And then that information is going to be kept with the local authority. We'll talk about that, who's going to be sponsoring your training. Rmaah already went through a lot of this information, so I'll pass over it now because my time is technically up. But today, if you are just taking the BEC TOT and you've never actually sat the 4 or 5 day course, we don't have an official role or name for you, but you are not a provisional trainer at the end of a provisional facilitator at the end of it. But for those of you who took the pen course this week, you will be provisional facilitators. Let me get to this part. So in order to register a course, for those of you who want to have your own BEC course, it has to be certified by IFEM or one of the accrediting bodies. In order to do that, you need to list the trainers who are going to be facilitating the course with you and what's their certification level, whether they're provisional, whether they're registered, or whether they're a master trainer, the number of participants that you're going to have at the course, where and when the course is going to be done, and then if needed, you can have a letter of invitation from the local organization that's asking you to teach the course. The accreditation oversight is provided by IFEM, and then regional oversight is done by the regional emergency medicine bodies, either African Emergency Medicine, Asian, FLAME, which is the Latin American organization and also covers the Caribbean, and then USEM, which is for Europe. And then you oftentimes will have other organizations involved, either a local NGO, a professional society, or a Ministry of Health personnel involved. All right. I don't think I'm running this icebreaker, but get ready for icebreakers. Icebreakers are huge during BEC, so think about how you can incorporate that. Any questions? Great, all right.
I'm Travis. Nice to meet everyone. I usually project enough, but so I am actually a community physician. I'm community riffraff here, but did residency at UNC and global health fellowship at Madison, and have taught TOT in Rwanda, Kenya, and most recently here in Philadelphia. So just wanted to go through how we approach the icebreakers when we're actually teaching the course, and then we'll actually do an icebreaker. So. There's different ways that you can incorporate it into the course. The way that we've done it most frequently is as you're in groups now, you'll also have groups, your participants broken into groups when you're teaching the course itself. And then each morning of the 4 or 5 day course, you'll have a separate icebreaker. And we have tried to make that based around the team in the past. So for our experiences, for example, the first day, we'll have them come up with a team name. And then the second day, they'll have a team mascot that they'll draw out, on a piece of poster board. And then you have a team dance or a team song. And as the week goes on, it's a nice way to kind of start the morning. And especially if you're in groups where people might be coming from different facilities or from different departments within a hospital, and they might not know each other that well, it really helps to get people comfortable with each other and prepares them for the sort of safe learning environment that we try to foster for the BEC. Any questions about that? Okay. So since we will not be doing a 5-day course and having team names and dances, I thought we would do something a little bit more conventional. Does everyone know how to do 2 truths and a lie? So essentially you'll do, go around the table and each person will say 2 things that are true about themselves, 1 lie, and then everyone else will try to kind of guess what is the falsehood. We'll take a few minutes to kind of get around, know each other in our smaller groups, and then we'll go from there. All right? Very good.
There's no notes on here. There's no notes on all this, is there?
I don't think so. It's whatever you guys if you send it to me, you have written it. Because I just copy pasted your slides directly into this.
It doesn't have any of my stuff that I've done, right?
There's one in that one.
Oh, okay.
Right there. But I saw
I think it's good. I think it's good.
You want me to just quickly do a little intro? And
Sure,
we'll get
sure.
started?
That sounds good.
All right, guys. We hope that you had a chance. We're going to go ahead and keep going. We hope you guys all had a chance to talk to your small groups and kind of get to know each other. Now that we've kind of done the icebreaker, I'd like to just go around the room and have everyone introduce themselves, their name, their institution, and their level of training. So we're going to start with our group right over here. You can just speak a little bit loudly for everyone.
Andrew Hosmore, I'm one of the combined emergency medicine and internal medicine residents at the Ohio State University. OH, Iowa.
Let's go to the table right here. Hi, everybody.
My name is Jess. I'm a fellow at Columbia University.
My name is Sharmeen. I'm a fellow at Brown.
I'm one of the residents at Columbia.
I'm Chad. I'm one of the little fellows from University of Washington.
I'm Shirley. I'm one of the residents at Columbia.
I'm Annie. I'm one of the global fellows at Mount Sinai.
Brennan Woolman, attending Columbia, Lincoln, and St. Barnabas.
I'm Chase Wester. I'm faculty at Mount Sinai.
My name's Shay. I'm one of the second-year residents at Emory.
I'm Eamon. I'm a medical student at Boston University, passing at North Dole at University. I'm Lee Bishop. I'm one of the global Olsen fellows from UAB in Melbourne.
My name is Nita Abrick. I'm EM faculty in Roseanne.
You just introduced
I'm Sonia Naganathan. I'm EM faculty at Central Health. I'm Carolyn. I'm a resident at UNC.
I'm Horace, one of the new residents at Seattle. I'm Travis. At the
Hi everyone, I'm Aisha. I'm a second year medical student at Ettingoff.
John, I'm a attending at Mayo Clinic.
I'm Justin, faculty at UNC Chapel.
I'm Nichole, Michaeli. I'm faculty at University of Vermont. I'm Aubrey. I'm with Boaglio. I'm fellows first year at DTMH.
Faculty at
I'm Ruben, it's a faculty at Virginia Commonwealth University.
I'm Emmanuel, resident at Stony Point.
I'm faculty at Stonebrook.
Rachel,
Savannah, I'm a fellow at Cloessner.
I'm Lee. I'm a resident at Boaglio.
I'm Maham. I'm faculty at Wieland. I'm Mara. I'm with DTM&H.
I'm Gil. I'm a global fellow at MSPH.
Sean, do you want to?
Yeah, I'm Sean Boaglio. I'm faculty at Emmanuel. Sorry that I said so many.
Again, Elise Janeska, Peace Emergency Medicine from Brown University. I'm Oluyinka. I'm a second year global fellow at GEMA. Charlotte Roy, faculty at USC, California version.
Michelle Baltus, faculty at Stanford.
Okay, perfect. All right, so Justin, you are next.
All right. Hello, everybody. Like I said, my name is Justin Myers. I'm a faculty at UNC in Chapel Hill. I have taught the BC course 2 times in Kenya and have taught the TOT as well. So I've had some experience. And just to kind of give you some context, and I think it's helpful when you think of this, the course that we're doing today, most folks that are taking the TOT have done the BEC, right? So they're kind of used to the rhythm of how things are done, how the lectures are done. And as you've probably seen, a lot of these lectures are packed dense with text, and it's done by design because a lot of times you're teaching in places that don't have a strong command of the English language, perhaps, or have other dialects, and so it's helpful to have the written English word and to hear. So that's why we like to keep it on there. But we also like to encourage that you can jazz up the slides. Now, the problem is there's not a lot of room to jazz up slides when there's so much stuff on it. So I always try to do some kind of theme. And I can also appreciate here that we have a room full of very experienced and even master educators, right? So I'm teaching this, but this is like what you would be teaching to someone that you just taught to the BEC course, and now they're doing the TOT. And so they may have had some experience teaching it, but they have varying levels of teaching backgrounds. So I try to put a little theme through my slides, and you'll see as we get there, and see what we can learn. So this is actually a pretty poignant question. Are teaching and learning the same? No. No. Very good. She passed. So your job is really not only just to teach, but it's ensure that people learn. And I think about this. I have 4 kids at home, and so all the times I'll teach my kids or tell them to do something and realize that they didn't actually learn how to do it the next time I have them do it. So this is just a cartoon that comes with the BEC, and this is the Peanuts where Charlie Brown says, "I just taught Snoopy to whistle." And Silas says, "Funny, I don't hear him whistling." And Charlie Brown says, "Well, I said I taught him to whistle. I didn't say he learned to whistle." And so that's a good example that, you know, you can be red in the face telling people how to do something, but when they actually have to show you how to do it, it's like you can talk it through. This is how you intubate someone, you know, this is how you do RSI. And then when you put them on the spot, they're just like, ugh. So the folks that you're teaching, they have to, what you are needing to do is transition them from being a learner, because it's sort of passive, you're taking it in, and now they're teaching, right? And so this is one thing that you can emphasize. You don't have to be or prove that you're smarter than everybody. And a lot of these, sometimes in a culture that you teach in, the teacher is definitely like the respected sage of information, right? That's what they're used to. And so for them to feel like they don't know something can be kind of, you know, embarrassing, but that's what what you need to emphasize that, look, you're not looking to be smarter. You're just looking to take the material, break it down, and learn together. So I like maybe many of you, I don't know, but I've recently been fascinated / obsessed with ChatGPT as I'm understanding the power that this has, not only in my professional life and in your academic work, but also even at home, just making a schedule or asking for other bits of knowledge. So I thought, you know what I'm going to do? You guys are all, some of you are fellows and residents that are maybe going to become academics. And so how can ChatGPT help you with a lecture or that? So I've asked Chat throughout this lecture to help me out. So I said, you know what? I need a good picture of someone transitioning from a learner to a teacher. Okay. I mean, it's okay. He's good. He's now studying, and now he's teaching. So I know ChatGPT is a little weak on the image generation still, if you've noticed that. But it's something. It's a start here. So what makes a good teacher? So I asked ChatGPT, but I'll start with you guys. Let's see the table. Now you may have to think of a teacher you have currently, or maybe you have to really hark back that 8th grade science teacher, the qualities of a teacher. But this table, what makes a good teacher? Someone can break it down into simple words, make it digestible, and really have to know it to do that. I think you have to know back and forth the material. Please agree with me.
Somebody who cares.
Someone who cares. Yeah, that's right. And that's a good point. It's like there's a bit of an emotional connection there, right? You get to feel like that person has an investment. I think that's an adult learner. I mean, I'm not an expert in adult learning, but I think that's something an adult learner thing. Adaptability. You don't know how the environment, the teaching environment is going to change. That's right. You look like you were about to say something. No, you were going to say adaptability. She's going to say back to you.
I really respect whenever the teacher or facilitator is very learner focused, teacher centered, paying attention to what works for the
Yeah, so they're not just I've got this model, this preset idea, I'm gonna just, but actually seeing where they're at. That's actually right. Positive learning environment. Absolutely. And you guys hit it well, and ChatGPT agreed with you. I asked Chat, and it gave me a list. It said, what he said was empathy, right? Your teacher displays empathy, a passion for the subject, good clarity and communication, shows patience, adaptability, encouragement, and high expectations, and a sense of humor. It says you don't have to be a stand-up comic, right? But just something to lighten the mood. All right, so this is just a little bit of heavy theory, just on educational theory, but it talks about how adults learn. And the constructivist theory basically says that as adults, we are assigning new information meaning. We're not just memorizing rote information like you're studying for organic chemistry. It's just really not a good way to learn. So we do this we take the new knowledge and then we sort of fit it into the boxes that is based on our prior experiences and our prior knowledge. And so that goes to what you said about really knowing your learner, because you really have to know what they know so far. It goes with medical student education, knowing where they're at and then what's that next step to build onto that block. It's not like you're jumping to the next thing, what you would teach at PGY3, right? So it's really kind of building on the building blocks of what they already know. And so the BEC course does this in multiple ways. That's why we have small group sessions, we have active skill sessions. All these ways hit different ways that you can build on your participants' knowledge. And so ChatGPT broke it down. I said, say this easier, please. Say this in easy words, all right? Not all these big words. And so it says, we learn by doing things and thinking about what we did to understand and remember them better. Just, very brilliant AI there. So another thing is cognitive load theory. Another way to look at teaching theory. And basically it says, the brain has a set amount of information to process at the same time. So if you think about you're sitting on your ER shift and you're trying to like do a note finally for the first time 3 hours in your shift, and you've already had 15 EKGs drop down your desk, right? Does anyone ever experience this? You know, the 15 EKGs while, you know, also, doctor, could you place that diet order, please, for that bed, that bed 14? So that really like takes up your cognitive load. So I was actually asking Chad about GPT about something. Apparently AI also has a cognitive load problem as well. So, but actually it's because I hadn't paid, I think I hadn't paid for the version yet. So there's three components. You have your intrinsic load. That is like what it takes to actually concentrate on the task at hand, like, right? Like you're actually like the material that you're trying to think about, you know, like the skill of doing the tension pneumothorax and where it goes. The extraneous load is all the other like details. So that's trying to filter out someone talking over here. I don't know, whatever else is going on in the room that's sort of adding to that cognitive load. And then the germane load is actually the learning. That's where your brain is taking sort of that like random access memory learning and putting it into the long-term part of your brain. So your brain has all these things it's doing at once. And the goal is to minimize the extraneous load for your learners, okay? So that's controlling the environment, making sure it's not like if you're right next to a super busy like construction site outdoors, right? They have a jackhammer going, like that's gonna be really hard to learn. So kind of minimizing, controlling the environment, and also controlling how the information is presented. And so you want to increase the yellow, you want to increase the blue, minimize distractions. And then this is just something I asked ChatGPT to make a nice infographic of this, and it brought this up, which was a nice one if you were going to do a presentation. So I only bring this up to say, like, look, okay, you're pressed on time, right, to make a presentation, and this is like a little power of what you can do with ChatGPT. You just throw in some words, and it popped it up. You know how long that would take for me to make in PowerPoint? I mean, I used to just take hours. The arrow, getting the bend right, you know, the bend is such a pain. So it'll do this quickly for you. So there's 4 key elements of a teaching session that we do have control over. And one is the environment, which I mentioned. And so the temperature, like right now in here, it's a pretty nice temperature. But if it was hot, right, and you didn't have a lot of breeze, it really makes it tough to learn. Because just think about, man, I just feel miserable right now. The lighting, making sure it's not too bright, too dark, making sure the layout is a little cramped in here, right? Maybe not, we're sort of saying, you know, do what we say and not what we actually do. It's a little tight. You actually want to make a little better layout for your students. And then making sure that you have all the equipment in it laid out the appropriate way too. I asked Chad about this, and it brought up a good point, which is the emotional climate, like making sure that that it is a psychologically safe place. And I think like you should welcome mistakes and be like, that's, you know, oh no, that was not, you know, the exact way to do it, or, but you know, brings up a good point. This is how we can do it better. And so just making it very comfortable for folks to learn, making sure that everyone feels supported, no matter what stage of learning or what type of role they play in the hospital. And then a growth mindset culture. And I, like Emma was telling my kids that, you know, progress is more important than perfection, right? Like we're just trying to get better. We don't expect you to be perfect at this. And then making sure that you have a collaborative environment. And, you know, I can't underscore enough that like developing just kind of some friendships throughout the course with the students can really go a long way for learning. And peer-to-peer learning. So example is like you're sharing something and someone brings up a point and starts to sort of teach the rest of the group. Rather than being like, oh, hey, I'm the instructor here, you know, like letting that person teach you, let them teach others, and learning from them. And not only does that build like a good sort of peer relationship, but also you'll probably learn something. I learned that from these courses about like just the local environment, the local medical climate. So just being open to that. And this is, I asked it to, I said, hey, make me a cool infographic. And there it is. Again, something you could put in. So the set is just like setting like kind of what we did. We said, okay, the credibility is like, okay, you know, my name's Justin and I've taught this course, and you kind of get a sense of who is this person that's teaching you. You want to introduce the topic. somehow inspire interest, motivation, why it's important, how it can be beneficial to their practice. You want to know your learners' baseline knowledge. Again, I think it's helpful to know if you're teaching medical student, teaching faculty, kind of where they are, where they're at. And like any good talk or PowerPoint, you should have some learning objectives. And then this is just your presentation, like the dialogue. You want it to be clear, you want things to be logical, you want to be organized, you want to be engaging. And then also closing, like this is, you always want to end with a question. Any questions? And kind of give it pause. Don't just say any questions and move on like perfunctory. Like really give it time, let people think about it. And maybe there will be questions at the beginning, but at the end, those start coming out, people more comfortable. Team feedback, say how'd it go? Did this work for everybody? And then go on to the next steps. Okay, here's what we're going to be learning next. And then you can summarize. Okay, here's what we did in this session. And I don't know if you've heard of a guy named Mel Herbert, that small company called MRAP. Anybody heard of that here? So he's got a book out. It's called The Power of Being Average. And he credits his success, not only to his educational team, but success of MRAP to the fact that he is an average learner. And he said that one of his key things is that when you learn, like, he really needs to hear it again, So if you listen to how an MRAP session is, like they introduce it like a set, and they kind of tell you where they're going, and they do it, and then they re-emphasize the points, and at the end they say it again. They're like, okay, here's the main points again. And so he said that's what really stuck with him, because it's just a great way to learn. And you want to vary the tone and level of your voice. Sometimes I can be very monotone, and I've seen this before when I'm talking, and just the people's eyes, their eyelashes start going down, and I know I gotta like get a little higher voice, maybe a little, just kind of like get people a little more awake, because I can definitely do that. So just know how you teach and how you can be better at it. You want to emphasize key points. You want to move around slowly, not crazy, and you want to move with purpose. Sometimes I've done it where I can just kind of pacing, and that can be distracting too. But the good teachers I've seen is that you come up to something, to the table like this, and make eye contact, with people, keep going, and you can move on to the next table. I think that does help keep folks engaged. And you want to try not to stand behind the podium. A lot of times that means you really need to know what's on your slides. So I asked ChatGPT, I don't know, this lady is moving with purpose. I don't know where she's going. But you got to move with purpose when you're up here, all right? That's what it says. All right, so we'll just kind of blow through this. If you don't know the answer, it is, if it's appropriate, you can say, I don't know. And sometimes that actually engenders a lot of respect too, when you the expert, that's a very good question. I'm not sure, we can figure it out. If it's not appropriate to admit, let's say it's something pretty core to the BEC course, then you can do the age-old, and medical students cover years, age-old thing to say, let's ask the group. You don't know the answer. Or you can say, that's a good question. Why don't you look that up, and we'll get back to me. Or you can have a parking lot. This is actually really nice, because if one team has a question, it's very possible that everyone else is going to have a similar question too. So you can have like a whiteboard or a piece of paper, and you can put that question up there. And then at tea time, you can scramble through and find the answer, and then bring it up to the whole group. So it's a good way for everyone to learn. Don't ever make up an answer. You guys know that. It's just that can cause problems later. It can really discredit you later. You may find that as you're teaching, that students don't have some aspects of what you have. They mention naloxone. Rather than just move through it, try to get to the next thing, oh, you don't have it? Okay. Really drill down on that. That's a really good learning point that they're going to remember. So okay, well, what do you have? And what do you use, and what's the local customs here? And so that's a great learning point. If they are truly missing equipment that is essential to the course, then that's also something you can write down, where maybe they need to work on getting that, and how you can help them get that somehow. So as we talked at the very beginning, which someone mentioned, learner-centered over here, the BEC follows a very student-centered philosophy, and we try to engage them in many different ways. We're very strict on group size because any more than like one instructor to 3 to 5 students in small groups, it hinders the learning process. And you want everyone to get really good focused attention. We should be interactive as possible, and then we'll use the slides to highlight the concepts. Okay, so this might be the first time where, depending where you teach, where they get this type of exposure to emergency care, even though for you guys that are faculty, even med students, where you've seen the ABCD approach, drilled into you, that is actually kind of a new concept, that idea in a lot of medical, institutions abroad where that's a little different. So it could be the first time. So also being as supportive as possible. And this is where, like, let's say you have tea time. Really, it goes a long way to like get to know your participants, make friends, and that can be rather than sitting and kind of cloistering in your like instructor group at tea time, is really try to mingle and spread to get to know your participants. I mean, that's the best part of teaching the DEC in my experience. It's the relationships, getting to know people, their amazing backgrounds. I mean, it's such a rich experience. I haven't done the faculty mentor. You could assign a faculty mentor. I don't think that's necessary probably, but that's something you can do. And then you should make yourself available. You are training the pioneers of emergency care in country, and just want to show a little slide of this is our team in Kenya in March, and you can see some fantastic instructors that are here with us today. Nichole on the end here, who is so fantastic at organizing courses. I think you've organized quite a few of them. But this was such a great time. You really get to know your fellow instructors. And honestly, you're spending 45 hours with these participants, and you get to know them so well, and it's just wonderful. So here they are teaching. So you can see, like, very interactive, like, these are the participants acting as the patients in this scenario. And this is Dr. Simiyu, who was the leader of the course, who is the professor of EM there in Eldoret, Kenya. And so this is kind of unheard of, that someone of his stature would be up here on a table acting like a patient. And they loved it. I mean, they just thought this was the funniest thing, and he had a fun time. And they learned a lot. And then, I don't know, it got a little crazy here. So they appreciate your time and effort so much that this was something that they had done for us. And so, okay, I don't know exactly what's going on here. And again, this is where you can put a photo into ChatGPT and say, what is going on here? Well, apparently it's a fun and engaging cultural activity. This is accurate. We're wearing shukas, traditional Maasai cloth. It's a workshop training. It's cross-cultural learning, leadership workshop. This is correct. I mean, the vibe was casual and upbeat. I agree. Whew. Well, any questions? And if not for me, if for ChatGPT, just remember that even ChatGPT can make mistakes.
Is that the paid version?
What?
Is that the paid version?
I think that's you get one, and then what I was running into was, after it would do that, it would say, you can't ask any more questions until tomorrow at noon. And I was like, oh. And then I was asking very complex things like, hey, is it better for us to add on? We have too many kids now. Is it better to add on to our house? Or is it better to go buy a house and put some money down? I want to know the breakdown of the costs and all of that. And he was like, that's a little too much. I was like, we're going to need to pay for this. Any other questions? Okay, thank you all.
All right. Hello, everyone. I'm sorry I missed the beginning. I'm kind of double dipping today with the leadership forum. But my name is Rybarczyk. I'm the Global EM Fellowship Director at UPenn, and I'm the incoming GEMA president. Hope to see you all at the business meeting later this week. I unfortunately have to follow Justin and now kind of flip this on its head a little bit and talk about what not to do. So we had a lot of positivity there, and now we're going to talk a little bit from the negative aspect of things of what not to do. But it's really important to really think about ways to approach this course and things that you don't want to have perpetuate down the line when the people that you're training go off to become trainers and then take that information further out in country. So to Justin's point of, it can take a long time to correct any misinformation. It can discredit you. If you don't know the answer to something, make something up, or teach something incorrectly, and that then perpetuates down the line. So that's what the overall objective of this talk is to talk about what not to do during the course. All right, so first of all, don't skip the basics. The decisions made in the BEC were made for a reason. There's not a lot of time. It seems like a lot of time, hours and hours and hours. I think he said 45 hours in total, but it really is not a lot of time. As was mentioned, this may be an entirely new concept to the people that you're teaching. And so it's bread and butter to us. It's innate. We just do this all the time without thinking about it, but actually verbalizing that to other people, showing other people how to do that, it's actually a big challenge. And so don't skip the repetition. Don't skip the basics. Use that time well. Everyone has some holes in their knowledge, even advanced providers. So there are things that you're probably going to learn in this course that maybe at least the approach to it is a little bit different than how you do it. So everyone has holes in their knowledge. Be humble. Learn from this course. Take that forward. And then there might be some questions about adding on other skills and how to handle questions about advanced topics. So do everything that's in the BEC as it is taught. And then if you do happen to have extra time or there are questions that go beyond that, feel free to address that. Just don't take anything away from the slides that are there. So everything was made very deliberately in terms of the decisions for making this course. So keep that intact. And then if you have a group of physicians or a group of providers that have specialties that they want to take a certain topic in a more of another direction, add that on afterwards. You may come under some pressure from leadership to modify the course, but again, keep the course intact and compromise by adding on like an additional day to do an extra workshop or something like that if you need to. Okay. Questions about that? About the content in the BEC or keeping the fidelity of the BEC intact?
Is there a required order of operations?
It's generally, so as you go through the course, you do the lecture, and then you do the small group case scenarios, and then you do the skills associated with that usually. You can change around the order somewhat of the modules, but it's really important to start with like the ABCD approach first, because that kind of carries through all the other modules and stuff like that. So there can be a little bit of movement of some of the things, but I would try to keep it as much in the order that it is. You can break it up, so people have found that sometimes the participants can't take off that many days in a row. So you could do like 2 days and then, skip a week or two and then do the next 2 days if you really need to do that. So, all right. Do not impose your own teaching style and cultural style if it's not appropriate. So this is where it's really important to get there ahead of time. Before you start teaching the course, have meetings with the other facilitators, get to know a little bit about the healthcare system, how care is provided, and then also the education system, how people generally learn. Is it a lot of like lecturing? Do people do self-directed learning? Have they ever seen like simulation or anything like that? So, keep the course intact as it is, but also try to adapt things to what the local teaching and training style is and the local healthcare system, but then don't impose things up and above that if it's not appropriate. So again, know your audience. Expectations for instructions do differ. Pay attention to hierarchies and social structure within the group. So there's a couple different ways of actually doing the small groups. One, you can try to mix peer groups because oftentimes that helps engage people more. People then engage in better teamwork and like understand how to work as a team a little bit better in the emergency care setting. But if there's significant social hierarchy, that may backfire. So you may then want to separate out like midwives all together, nurses all together, physicians all together, depending on your group. So this is where it's really important to rely on your local facilitators and their knowledge of how this should work best. If you're going to, so again, you can't take anything away from the slides, but if you're going to add things, just don't put words on slides for courses or other things that are not in the participant's native language as well. questions about that? All right. As with anything in the BEC, repetition, repetition, and repetition, you're going to hear this again from me. Do not skip the repetition. Learning is reinforced by seeing things several times and by writing. And remember, why they may seem very basic to you, this may be the first time participants have ever heard these concepts. So I tell people, go through the lectures ahead of time, the lectures that you're going to be giving, and look at every slide and think about every word on that slide. If someone asks you, what does that word mean, you should be able to explain it in very basic terms, what that term means. So like dyspnea or like difficulty in breathing or something like that. What does that actually mean? And be able to explain that if someone were to ask you that, one of the participants were to ask you that. Okay. And don't be afraid to ask, especially if it's an area that you're not familiar with. That's why it's really important to have meetings ahead of time. Like, ask the facilitators ahead of time, try to prepare as much as you can, but ultimately, when you get in the environment, there's probably going to be stuff that you didn't think about. And so as you're working with your small groups, as you're getting to know your participants and working with them, don't be afraid to ask. To that point of, if you don't know the answer to the question, ask the participant to come up with the answer. Ask them also too about limitations and challenges that they face in their setting, what types of supplies they actually have access to and things like that. So don't be afraid to ask. It's going to help them warm up to you as well too and work with you if they see that you're, number one, interested, and number two, that you're not like the expert and all, like know everything, and that they can teach you as well. As I mentioned, don't underestimate your champions. Try to validate leaders in your group, ask for their input, and incorporate it. Again, remember that they are the experts. You're not, specifically in the local setting, so rely on them very heavily. This is another one too. This can vary a little bit by the group that you're with, but try not to let people sit quietly. Obviously, we all learn better when we're engaged and we're interacting. People are answering questions, asking questions, but do be a little bit careful with this because it may not be appropriate in some instances to really put people on the spot, or at least in like a group this big, put people on the spot. But when you're in a smaller group, maybe it's okay to ask people questions. But as much as is appropriate and is comfortable for everyone, engage your learners, ask questions, ask people to summarize. That's really going to help people engage in this course. All right. Any other thoughts? I know I went through that very quickly, but I'd love to hear from the group and especially the facilitators who have taught this course before. What are some of the pitfalls you've encountered? What are some of the learning points that you've taken away? I'll start with Group B up in the front. Anyone who's engaged with the BEC before? Pitfalls, lessons learned.
I don't know, lessons learned, but like as a beginner, like you would want to teach this course and, you know, like kind of having that input from like local providers and what's what the learners would need. Like, would you just like set up a day like beforehand to kind of go through all the lectures with them, or kind of what do you recommend for approach?
You're talking about working with the facilitators, like you're already working with,
Or
or?
just like the local community and
I would say at least a day before. You're probably gonna need a couple days before, honestly, to like work through all the logistics, like last minute things of like, do you need to print anything off? Do you need to like get everything set up, like setting up the environment and all of that? So I would take a couple of days, like one where you're just kind of like talking through the concepts and like getting to know people, that kind of stuff, and one where you're actually like doing the logistics of like, this is where all the chairs need to be and like getting the director and all that kind of stuff. So I was trying to schedule a couple of days.
and in terms of like content as well.
Yeah. And like making sure that they like maybe so as we're going to talk about later on, like how you go through the course in terms of becoming like a registered facilitator and a master trainer and all that, like especially if it's the first time that they've taught, like really going through things with them, making sure they don't have any questions about anything. Back to this group here. Experience with the BEC and lessons learned.
I think it's helpful to take in on the course too, obviously, and see the learner perspective. I taught one and tried to like do a Jeopardy style with like different parts of the room, and subsequently realized that the lecture material is the exact same as what's in the handbook. So like everybody had every answer in front of them. It was a little awkward, but it was helpful to have seen the workbook and everything.
Yeah, that's why at least in the process of being able to teach the BEC, the best order to do it is to take the BEC, then do the TOT, and then go on from there. Just because, like, even though you might know all the material in the BEC, just the way that this course is specifically designed and taught, and repetition, and being able to explain out all those terms like more basically, is very different than what we're used to. And kind of having to bring everything down to a more basic level, that we're going to be doing here is probably some of us. So, so it's really important to go through the course and see how successful first. Yeah.
I would echo what you said earlier about logistics. At these 2 days before testing, you think, oh, how long did that take, or how simple would that be? You will be stunned at how long things can take if you're operating. And you can just something as simple as printing can take an entire day. So I definitely factor in.
We shot easy.
So, I think the question is specifically what your experience with, teaching like responses.
Yeah, pitfalls, what not to do.
Yeah.
What
I think one major thing that Megan talked about at the beginning of the lecture that I find really important to stress is just making sure that if you're teaching a group of people who are maybe their culture is more serious, so standing up there and having more like casual interactions, joking with them, maybe more disrespectful and distracting. And our goal is to teach and ensure that the learners are learning. And so trying to avoid those distracting, like I have a very colloquial and like to really engage and like joke with the audience, and in some forms you have to be aware that that's not okay.
Yeah, avoiding idiom, slang, and joking, unless it's very closely covered, or you have like a group that really good to well. You want to this?
Not of course, but in places where English is not the primary language, do you try to make sure that there's a facilitator who's bilingual in the local?
I think it's important, yeah, to have someone there, yeah, who can help explain. When we were doing this in Pakistan, when we needed some time at the end for people to remediate, we paired them up with someone who spoke Urdu and like have them go through all the concepts and make sure they had all the questions answered before I could. Unfortunately, like the slides, they're quality. There's some translation of the actual book, but not the slides, or maybe in Spanish.
Spanish.
Yeah, Spanish and English only, but not in English. But a good project for folks to do, especially if you have champions in the country who are like really into the course and they teach a lot, like maybe they can provide the translation for that.
Any other folks along the back wall here? Lessons learned?
I would say one of the more important things that it's been said before is just that collaboration with your local facilitators, because they have so much insight in terms of what the culture is. My family's from the Caribbean, and I've been fortunate to work in a lot of places in the Caribbean, but that was very different than my experience in working with Ethiopia. And having that lead time in advance to just talk with everybody about what is going to be okay, just even in advance, like in Jamaica, for example, people curse a lot, but not at all in professional settings. And so, you know, as EM professional, sometimes words slip. But it was kind of like a shock for anyone to be able to hear anything like that. So that's, it's just important to recognize that and to be able to talk to your local champions about what is appropriate and what's not appropriate. And then even figuring out things like hierarchies, because sometimes you're teaching to physicians, nurses, EMS professionals, and are physicians going to be comfortable with EMS professionals teaching them, and knowing that in advance can help you in terms of how you go through small groups. Like, can you really force 3 different groups to be together, or do you really have to separate the nurses, the EMTs, and all that? So just having that lead time in advance. And these are all things that can be done over Zoom beforehand, if you're not necessarily able to meet, you know, a week ahead in the country. So keeping that in mind as well.
Piggybacking on that, there's also potential if you have kind of mixed levels of training, so like EMTs for physicians, etc. Are physicians going to be comfortable asking questions in front of EMTs or nurses that they're working with clinically? And that's a really important question to ask before you schedule the sessions. because you need to know if it's even appropriate to have the mixed groups at all, or if they really need to be done in separate rooms or separate times.
Just to piggyback off that point, it's great to have like a ton of Zoom meetings ahead of time and get to know your other facilitators as much as possible to be able to ask those questions. But remember, sometimes in the country, you may have like zero connection to the internet, all depending on where you're teaching. This happened to me in Ethiopia. We couldn't even like upload the slides or anything. Everything had to be prepped ahead of time, printed ahead of time, and like we had zero internet connection at all. So you may be teaching it in an area where that happens. So try to have a backup plan, if you need that.
I was just going to emphasize the importance of really trying to strengthen the capacity of the people that you're training in the TOT infantry. And the way that I've done this with one of the organizations I work with is this cascade model with peer teaching. So we hold a BEC with people either from in-country or out-of-country, followed by TOT, and then we do another BEC the second week, and we bring back the people from the TOT and partner them as one of the experienced instructors, so that they really get that peer teaching and correct anything that maybe they're doing wrong, but also just provide some mentorship. And I think that just really helps, because after you take the TOT done, you're ready to go out and teach it for the life.
Yeah, that's a really great point. Just because, like I said, a lot of the stuff seems very basic, but just think about, like, for example, doing bag valve mask ventilation. And if someone just gets their hand position a little bit wrong, and puts like too much pressure, and like the way that they're doing it actually occludes the airway when they're trying to bag someone, and then that's the person that goes out and teaches 100 other people that same technique. So very, very small things can have a huge impact on this. So pay very close attention to how people are actually doing things during the course, and find those champions and have them have like shoulder to shoulder teaching and training as they're going out to do it as well too, so that none of those mistakes get transmitted out down the line. Awesome. Any other questions? Thank you very much.
All right, guys, so we're gonna do a 15-minute break, so you can get coffee. There's food downstairs apparently as well, and then be back. It's like 9:53 right now, right? So like at 10:08 or so, be back.
We had great
Yay! Thanks, Brenda. Oh, thank you.
How long has it been? And I think I saw like two that you guys had it's like a monthly faculty. That's amazing though. I mean, I feel like it's so discouraging, honestly, because the artists don't. But super supportive. Yeah, so they have. Oh, yeah. No. Nice. That's like really. So like the faculty is like a is like. When I was full time, I never did writing unless I went to I was there for
And honestly, that should take on it is actually very good. It's tough. Like that's the thing for me that's been not they're all trying to sell me. Like if you are like this is maybe doing it too.
Check. 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 Check.
Are we gonna have to do like an ABC? Yeah, I can be your mannequin. Yeah, I can be your mannequin. Wait, are you gonna be where? I have to leave Thursday. Yeah, pretty much. I'll work this out. Yeah. I can. Yeah. I'm not the best at it, but like, sure. I mean, I don't know. Just whatever. Maybe I have, maybe dreams or like, I don't know what's dreams or reality. Maybe that's what it was.
Oh, no, the last time I went, the last time was like, I went to the shop. And it was, the line was, like, but I don't know if that was just because it's ASAP. I mean, like, it looked like a fail. That was also like September, October.
Oh, it's like they're visiting all the
Like,
time. Yeah.
really, you have to walk by and see it. And I'm like, that's good enough. That was good enough. But,
Anything. Oh, yeah. I know. I was gonna, yeah.
like photos and they put like they have like almost like frames. I might watch that. I just might have to bet.
Oh, yeah, that's different. What year is your?
Part of the reason that I haven't switched.
Oh, yeah.
Like I started on like, yeah. And then people say, yeah, but, and I'm like, yeah, but I still do that.
Yeah.
And then like, I think it's also, it makes you better. Like getting texted live. I also try getting lucky. Some girls do that. I thought you were asking why.
Can't find the device. They took it away. It's always, they always do this. It's like you gotta get in there in the morning and it's game over. But otherwise, yeah. I think probably lunchtime is the next thing. There's definitely one place where I all
For the form,
are.
and I did it, now I can't find it.
Okay, I think we're going to regroup. If everyone can take a seat, please. So again, I'm Charlotte Roy, based in LA at USC. I'm going to be talking about how to give a lecture. And as the backup lecturer for this lecturer, who found out a couple hours ago she was giving the lecture, definitely preparedness is so important. And I indeed am prepared. I mean, that would be crazy to give a lecture on preparedness and not be prepared, right? So I went through this lecture multiple times in advance, like even months in advance, just to be as prepared as possible. So I'm really happy to be here. You guys are giving me dead stares. Okay, so we're going to talk about keys of giving lectures. As we mentioned previously, there's a lot of repetition in BEC. There's going to be repetition in the TOT as well. So some of these things we've talked about before.
We're going to talk about advantages, disadvantages of lectures, the kind of slideshow presentation format, ways to deliver an oral presentation, and engaging with learners. And two things you'll hear again and again are preparedness and engagement are, I think, the keys to success here. So advantages, slideshows are a great way to give a presentation to a large group of people. You can deliver it, in a way that it's hard to do with small groups. You just need more people to do that. And it's also a great way to give multimedia content. So you can have photos, you can have videos. I think I personally really benefit from being able to see what's being presented. When people do kind of more free-form lectures where they're just talking, it's really hard for me to absorb that. It's just not the way that I learn. So I think it's nice to both be listening and also be reading. And it gives you kind of a broad overview of the topic. Limitations, I think we're all very aware of some of the limitations of PowerPoint presentations. Some of those you might be experiencing right now, right? Especially in BEC where the training days are pretty long. It can be boring. It can be easy to kind of lose people, lose engagement. Also, everybody has to kind of learn at the same pace. And particularly with BEC, often you have a diversity of learners in the room. You have paramedics, nurses, doctors, and they are coming at this with different levels of knowledge. And so it's hard to both teach to a level that's acceptable to somebody who is, for example, a basic EMT, but also in a way that's engaging to the person who is a doctor who previously worked as a trauma surgeon. So planning for the presentation, make sure you have a good understanding of what your learning objectives and key points are. Engaging people, we'll talk about various ways to engage the audience with different questions. I definitely like to, so typically when I'm giving a lecture, I will rehearse the night before or like even a couple nights before with a timer. That way I have a sense of like how my pacing is. Am I going too fast? Am I going too slow? I know personally I usually go too fast and finish early. And then kind of thinking about where maybe do I need to clarify, especially if this is day 2, 3, 4 of this BEC course, and you've already kind of gotten a sense of the level or maybe which topics like clinically are more or less familiar to people, then you can kind of adapt your slides to that. I like to plan in advance, where am I gonna pause and try to do some audience engagement? And you can also do that on the fly, right? But sometimes it helps in advance to have specific points where you've planned to stop and ask people a question. I feel like I rarely actually use the notes when I'm presenting, but it helps me think about it to at least write them down and prepare that in advance. And then make sure you finish with summary, give people opportunity to ask questions. So again, preparedness, so important and something that I am really good at personally. So make sure that you're prepared, that you've gone through things well in advance. I think this is particularly true. I don't know if anybody here has ever lectured in another language. Has anyone ever done that? Yeah, it's extra super hard, right? So you have to both be prepared for the content, but also for any vocabulary you're going to need to use. What are some effective presentation skills? So thinking about what we talked so far in your personal experience, what makes somebody an effective presenter? Just like throw some words out there. Pacing. Good, interactive, so engaging the audience. Good energy. Yeah, so make sure that you're communicating clearly, that you're, particularly for BEC, where often your audience is English second language. If you're delivering the presentation in English, make sure you're speaking slowly enough. Make sure you're using terminology that people understand and avoiding jargon. Also kind of using consistent terminology throughout the course so that you don't confuse people by switching up the terms. And then make sure you're projecting that you're speaking in a loud enough voice if you don't have a microphone. Use of voice. So you want to, like somebody said, make sure you're giving across some level of energy. I feel like we've all been in a lecture where the person is speaking in complete monotone, and no matter how interesting the content is, it's just like very hard to kind of stay engaged with that type of lecturer. There's also such a thing as varying your voice too much, which can also be a little distracting. So you have to find that kind of happy balance. Smile, you know, somebody brought up, I like to use humor in lectures to varying degrees of effectiveness. I think, like, yes, yes, the actual content of the humor and what's considered like culturally appropriate humor varies, but I find that, you know, everybody wants to smile and laugh, and so I think that's something where you kind of feel it out as you go, you know, how to integrate humor, and I just think it's a good way to kind of bring energy into the room and loosen people up a little bit. Be aware of what your bad habits are. So everybody has their own speaking habits. That might be saying, it might be coughing, clearing your throat. It might be that you start to talk really, really quickly. I know, and I am hesitant to tell you this because now you're gonna start picking up on it, but for me, I'm very much like a nervous laugher. I'll like kind of laugh at times when, sometimes it works and sometimes people are staring at me like, why are you laughing? What's wrong with you? So being aware of what those habits are and then trying to adjust for them. Okay. And then making sure you're engaging the audience. So here it's always sort of weird when you have a podium and a microphone because you kind of feel like you are supposed to stay behind it. But generally in BEC, it's very much about walking around, keeping people on their toes by physically standing next to them and hovering over them, and making sure that you're engaging the audience. There are different ways to engage the audience. You know, I think question and answer can come in a number of formats. So one way is to ask a question of a specific person. I had a conversation about this with a friend of mine who's an English professor because I feel like amongst the Gen Z, it's sort of now considered maybe a little bit inappropriate to like target a single person. So I was talking with her about whether or not people still do that in teaching. You don't necessarily have to target one person, or if you do, just be ready to kind of pivot. So if, for example, I'm asking you and I say, so what's the difference between a pneumothorax and a tension pneumothorax? Also, when somebody's chewing is like the best time to target them.
The biceps. I don't know.
So if I had sensed that she's kind of hesitating or that she, I give her a moment to try to answer, but if she's sort of squirming in her chair, I'm not gonna like stand there staring at her right and say, does somebody else want to help her out? Anybody else can you answer, what's the difference between a pneumothorax and a tension pneumothorax? So just making sure that you're not putting so much pressure that people are uncomfortable. Or what I like to do is more ask a table. So for example, if I can sense that like people in the back are starting to fall asleep, I might be like, well, I think it's a back table here. And then everyone sits up a little straighter and they're a little nervous. And I say, can anybody here tell me the difference between pneumothorax and tension pneumothorax? You all know the answer. Everyone phones. So also, depending on, I like to also do kind of like small group discussion during a lecture, but I will say the BEC, the content is quite dense and it tends to be challenging to get through the lecture in time. So usually you don't really have time for that. Sometimes people will kind of break down into individual conversations, and so then it can be challenging. You have to try to bring people back together to maintain focus. I think also asking a targeted question or asking somebody to explain. If you're explaining something on the slides and you say, everybody understands this, right? Nobody is going to be like, not me, I don't understand, right? Nobody wants to be that person. So instead of doing that, saying, can somebody explain to me again what this concept means? and asking a more specific question. When somebody gives an answer that's incorrect or partially correct, there are ways to respond that doesn't make them feel overly singled out. So I actually do most of my training experiences teaching ultrasound, and if I say, can somebody tell me what this structure is? And they say, it's the heart and it's the kidney. I like to do a, Just like, what does everybody else think? You know, that way I'm not kind of calling that person out, but I'm saying, that's not quite right. Let's see if someone else can give the right answer. And then I think also sometimes validating the portions that are correct, or for example, saying, well, I can see why you think that, because, you know, it's this is similar to the view we usually look at for the heart. I don't know, I'm making it up. But you can tell that, you know, this is the kidney because it has this hypoechoic exterior, and then we have the interior part, and there's no movement. And so kind of acknowledging maybe what they were thinking, but then helping them correct. Answers that are wrong. So if somebody gives an answer that's just like flat out wrong to a question, I'm not going to be like, incorrect, right? That's generally not well received in any culture. So instead, trying to give them a chance to correct, say, well, what about this? Or is that a sign of shock? Or is that actually a sign of good perfusion? Okay, what would a sign of shock be? So those are different ways to kind of redirect the questions. Also, I think Justin mentioned this before, but opening it up to their peers. So saying, what do other people think? Or can anybody else help explain this topic? And that's also a really good way to engage people who are higher level practitioners, like doctors, by having them engaged as teachers of the content and not just listeners. Remember that when you're presenting, you're both giving and receiving information. So you're giving information, but I'm also constantly looking around. Are people listening? Are they giving me confused faces? Are people falling asleep? There's a confused face over there. Making eye contact with people. And I'm always kind of trying to read the room and sense whether or not what I'm teaching is getting across correctly. And then also acknowledge the experience people are having. Hey, I know it's really hot in here. It's not hot in here, but you know what I'm saying. Or, hey, I know it's a really long day and it's almost lunchtime and people are tired. And maybe giving people an opportunity to stand up and stretch for a second. Things like that. Make sure you give positive feedback. Make sure that people are understanding and that you're giving people opportunities to ask questions. And then, of course, audience engagement. Answering questions, make sure that everybody can hear when a question is asked. So if an audience member asks a question and it's a big room, or they ask it kind of softly, repeat it so everyone is on the same page and knows what you're talking about. Like we talked about, if you don't know the answer, it's okay to say you don't know the answer, or to say, I'm not sure, but let me look it up and I'll get back to you. And then, you know, after the presentation, you kind of circle back either with the group or with that individual to answer the question. So again, preparedness, engagement, make sure you're using effective speaking skills in terms of your voice and your pacing, your energy. Make sure your learning objectives are clearly defined. And now we've come to the question and comment portion. Any questions, comments, thoughts based on your experiences about how to give a lecture? So the next activity is we are going to practice giving a lecture from your assigned slides. So you guys should have reviewed the slides in advance. I think you want them to present one slide, right? Okay. So everybody will select one slide that they'll present. So you have 5 minutes to present that slide. And remember to think about all the things that we talked about, the to-dos and the not to-dos. And yeah, we'll break into our groups to do a little practice.
For facilitators, there's a group assignment in the Google Doc. If you can make sure that you're just seated at the table that you're assigned to. Yeah.
Aside from the one person who moved from the bachelor's group to the front people.
Yep. Perfect. For those that have a laptop with them, the ABCDE lecture was included in your pre-course information email.
She's like, shut the sweater. I got it. Yeah, that's like it.
Yeah.
We're going to be talking about the egg for
plenary abilities, one of the things that you have there is your perfect. That way you summarize it with a perfect math. And then the biggest thing, and don't forget the having questions, right? And that is So we have a person in here also vomiting, complaining about. All right, so we describe what is needed to see like that. And their makeup birthday. What do you do? Call them. In consideration of context, someone's coming with vomiting and bleeding from mouth. You're literally you're gonna be so close to their face because you know they're away. So you might want to put experts in their face. And then think about bleeding, Nichole infectious disease.
And when it's playing right now. I don't know if I'm also.
So we're going to need that for assessing breathing things. Biggest things that we need to go over. sometimes even just in people bring that medical stuff. And then of course we
Face training.
I'm happy that she's I felt like not happening. Like I thought, wait, I think they changed. But like you was like from the board and like worker flags
Yeah, exactly.
Yeah, they did. And then that's really like thinking about putting in blood. Then you're like, yeah, even if you see something that's bleeding, you're doing this like and then I want to you guys are bleeding in here. Realize that, but you're also making sure you guys say, oh my god, that's like my so one conclusion that happened is that now so we're giving you a little bit of assignment. So all of us need to grab that and read some songs and you know like that.
I was like, I've never learned that this stuff. That's like, yeah, but I, switching from how to,
Hey guys, we're gonna try to wrap up in the next 5 minutes or so. So just like go ahead and take a quick bathroom break if you need one, and then hopefully we'll get started again with the next lecture. If someone did not receive the water bottle, let me know and we will escalate. So.
Is everybody done? Yeah, so I think we're the last session. And everybody step back. I think it's like all bid first, like, so right now. Like, what is it? Yeah, I do. Yeah. Hi, everybody. Are all the small groups done? Okay. This microphone is actually really loud. I'm going to start the next session, if that's okay. I'm Nita Avrith again at Mount Sinai. I've done the BEC in Tanzania with a group of nurses, and I just want to put a little plug for the BEC. It's so incredible to see. We initiated it in 2020 with a small group of nurses, and they've gone on to train 250 nurses in that hospital and in the surrounding area. And it doesn't just improve knowledge, but also changes the culture and the confidence, and really, they really embrace it and they love it. So if you have the opportunity to implement this, it's really incredible. Okay, so I'm going to talk about the case scenario sessions, and you'll get the opportunity to practice that next. At the end of each module, there's 2 case scenario. One's usually adult case, and then the other one would be a pediatric case. And so this is really the opportunity for the participants to apply the ABCDE approach and everything that they've learned into a theoretical patient case, and to see exactly how it works. You've kind of done your work giving the lectures and done all your talking. This is kind of your chance to step back and let the participants really sort of lead the case. Your job is more just to supervise, make sure they stay on track, make sure they're reaching their goals, and make sure everybody's engaged, kind of thing. So, like I said, as the group lead, you want to make sure everybody's working together to solve the problem, and that they're using their collective knowledge. Sorry, this is the group role. The group's job is to use their collective knowledge and resources, and you want to maybe have them elect a team leader to be taking notes, and then to be able to provide the summary at the end. At the end of the day, they all have their own manual, and they should all be writing the responses down, because they have to fill out the manual to complete the course. But just having somebody sort of maybe taking the notes during the actual session and then having everybody afterwards write it down is a little bit helpful. And then your role as the facilitator, you want to set the scene, kind of explain how it works. You want to encourage discussion and debate. You want to, make sure that everybody feels safe in the environment. There's no wrong questions. You want everybody to speak up. You want to ensure everybody's participating. I'm not one to point anybody out. Sometimes it's a nice idea just to break it down into small sections and sort of go around the table or your small group. Oops, sorry. And then make sure everybody gets a chance to participate. Just going back to setting, the scene. Just in this room, we just broke up into small groups, and it gets really, really loud. So using your space as best as you can, and trying to space out the little teams. Groups of 3 to 5, I want to say, work best for this activity. If you get too many people in a team, not everybody gets a chance to participate. And I guess if there's too few, that's not really ever a problem, but you want to use the collective of the team. So only really intervene if the participants are on the wrong track, You want to validate correct answers and repeat some key learning points. So going back to your environment, usually typically for the actual lecture component, they're sitting in rows or sort of groups like this, but then you're going to want to group out or sort of have everybody sit separately for the small groups, right? Sometimes this is an opportunity to get outside of like the classroom, go outside if it's a nice day. Just make sure that you can like get everybody back into the classroom at the end of it. You want to set a clear opening statement and explain your role as the facilitator, so they're not expecting you to give all the answers away. And then it kind of runs like, I'll show you in a bit, but kind of runs like a oral boards kind of case. So they have to like ask or prompt the right questions for them to get sort of the read or the response of what the patient's doing in the case. Dialogue, allow the group to have a conversation. Facilitators should also join in the conversation. And then you want to close with a clear summary of what the group has learned. And if there's any questions or comments, that's the time to address them. So I won't go too much into it because you're going to get a chance to do these in just a second. But this is one of the case scenarios. So you have like a little prompt of a patient who's coming in. And then the first question's always the same. It's what do you need to do in your initial approach? And I'll ask the group. Does anybody know? Yes, Alicia.
Ensure that your scene is safe.
Yes. PPE. And call for help. Perfect. Okay. So you got it. And then the next portion is similar, is use the ABCDE approach to assess and manage this patient. You really want to emphasize that they need to look, listen, and feel if they want to get information on the patient. So this is what the facilitator guide table looks like. But the participants themselves will just have that first kind of like column with airway, breathing, circulation, disability, and exposure, and then like the titles on the top, assessment findings, intervention needed, yes or no, and then intervention to perform. So you kind of want to like prompt them, okay, for the airway, they're going to ask, how do we assess the airway? And then this is, so how do we assess an airway? Does anybody? What is that? And how do we listen? What are we listening for? If they're breathing, if they're talking, that kind of thing. And so if they're asking the right questions, the look, listen, feels, then you can give them the findings for the patient. And then you can sort of guide, is an intervention needed? And they can say yes or no. And then what interventions can be performed. I think the first time they do this, they need a lot more guidance, just kind of figuring out the structure and the form and how this goes. And then you'll see by the end, they're, taking it on their own and they're able to do like a full case by themselves. And then really important, the handover is like one of the last kind of skills, and is at the end of the booklet. But during these case scenarios is a really good opportunity for the participants to practice doing a handover. So whether they're at like a tertiary care center and they're just handovering from the ER to the ICU or to the inpatient floor, or if they're from like a primary care center and they're transferring the patient out to a higher level of care, they need to practice sort of summarizing and doing a handover. And the VEC teaches the SBAR handover method, which, does everybody know what SBAR is? No. Great. So situation, it's just sort of like a 1 to 2 line summary of like the patient, their age, their sex, and what their presenting sort of complaint is. I think this is something maybe that nurses go with, practice a lot more than we do. But so situation, then background, what are some of the key things from the ABC that you recognize and that you intervened on? And then assessment, what you think is going on with this patient. And then when you're transferring them, recommendations, like, I'm really concerned this patient's airway might be compromised. He needs to be like frequently assessed. He might, need a definitive airway, etc. Yeah, like I said, it's really at the back of the handbook. So if you wait till you get to the end of the handbook, you don't have the opportunity to practice. So this really pulls it in early. Handover should be given anytime care is transferred to a new provider. We sort of already went through this. The S bar, here we go. Situation, background assessment, and recommendations. And like we said, this is a new skill for many of the participants, including sometimes ourselves. And so we'll get an opportunity to practice during these small groups. And then at the end of your activity, you always want to ask, what did we learn from this activity? And see if there's any questions or comments. Any questions on or comments on that? Okay, I think let's try. So I think we're back in the same sort of small groups for this.
I live in Texas. Yeah.
There was no trauma, and the daughter told us now he's perfect.
Alright, guys, so you are coming moving forward. And brought in your for husband, 40 years old. And through a volume of abuse. And my state said, well, strong order. And then So what do you want me to do? Oh, for this money to do your wage. Do you want to do a training? So, what I know is that respiratory rate is 28 breaths a minute. Do you want to intervene? Well, we do have your basic interventions available. You would have the same thing. We can certainly do that. All right, your exams is yes, inhale. You feel the pulse and clean up a bit, and then you have refill and into a pulse. Oh, but I mean,
But there are
That was hard to do. The conference, I just assumed, I mean, obviously, I was like, baby, or like moderate based on it. Like, if you want to case, people will to get, I think I just relied on the fact that it's. So now I think it's from the extension. We have a rash. Yeah. They had the power department. I lost the students. Yeah.
Okay, guys, so every group has now finished up the case scenarios. So we have lunch outside. You'll just have to give your little slip card to the people outside to get lunch. So the thing is, lunch is arranged for an hour, but if you guys are interested, we could do a 30-minute lunch and just continue the workshops. You guys can get out early. What do you guys want to do? Early? Yes. Okay, so just get your lunch, be back in 30 minutes, okay? So be back at 1:03 or 1 o'clock, okay?
Yes. Yeah. Right. Oh, yeah. Because one of my best friends from residency here, we're having like pocket and they're still open. So even today, when it was like not many people there, he was like, that's so funny, yeah. Like the first time I had the gut feed, yeah, no one else the door. Because there was probably not one.
Come back to us when you left. All right, guys. Do you guys want to continue on our trajectory of being done early? Yay! All right. Hey, everyone. I'm Dr. Boaglio, faculty at Vanderbilt, and
you know, whether it's a blessing or a curse, I get to talk to you guys post lunch. And now we're all in food coma. I hope everyone's feeling good after some sustenance. So, teaching practical skills. This, I find, in teaching courses is often like your resurrection chance for regaining concentration, engagement, enthusiasm from your learners, because everyone, you know, nothing quite wakes you up like sitting and listening to lectures back like when you're in medical school. So, teaching practical skills. Has anyone else raise of hands, like who's, you know, I think we've all gotten to be able to do this either in residency or other things. Who's gotten to do this at like a BEC or something like that at this point? Yeah, all of the instructors, no surprise. So the framework that you can use to try to be able to help you as you're facilitating a BEC course and every skill that you're doing, this is a framework that BEC provides to help give you the right language and help you assure, like what Justin was telling us all about, there is a difference between teaching and learning. Teaching is us conveying the information. Learning is like an end result of the learner. And just like you're using these very similar concepts for conveying of knowledge, for teaching that and showing that they learned it, there's some nuances to engage with doing practical skills education. First, engage, set the scene, engage. Why is this important? Why do you need to learn this skill? Demonstrate it, just do it. Show it in its completion and entirety. Redemonstrate it whilst explaining how to do the procedure or the skill. Explain and then supervise your learners while doing it. And then the final one is my favorite, have the students explain while they're doing it, or have the students teach you a teach back, or have them literally like you be their hands and they tell you step by step how to do the given skill. Say as I do, don't do as I do as I say, don't do, well, you know what I'm trying to say. Try to minimize your amount of time talking when you're teaching practical skills. Maximize your amount of time with hands-on, and that's a logistics you're gonna have to think about. Like how much materials of a given skill practice do I have for my groups of 4 to 6 learners per table, minimizing the amount of time that everyone else is just sitting there twiddling their thumbs, maximizing the amount of time that they too are working hands-on, that you as 1 to 2 facilitators per group can like maximize your attention to giving that instruction. Do the same things that Justin talked about when you're trying to teach in general for didactic content, your environment. You wanna make sure that your environment is conducive to learning skills. Minimizing like different skills overlapping on top of each other. You have to allow like a little bit more movement. Maybe you need to physically move your team into out in the hall or other to physical spaces, or more move for you and your learners to interact and do the required motions and not be trying to hear over the top of each other, someone else putting in, immobilizing, log rolling, and you're trying to do airway maneuvers. Granted, here we are, we're making the best of what we can in this Salon L, but try to address that. You want to set the scene, set the standards, the expectations for what you're going to be doing, why you're going to be doing it. Discuss the purpose of the skill. Something I always encourage residents and learners or educators when you're trying to teach a practical skill, not only emphasizing how to do it right, emphasize the common pitfalls. Emphasize this is how everyone's going to mess this up, or you emphasize that up front, and it really helps things go smoothly and solidify for them. Dialogue, use that framework of those 5 steps before to really help get you through a framework of that and secure that they're going to end up learning the thing you're teaching them. And then at the end, close summary, chance for questions. And even back to setting, I think clarifying your learners what their comfort level with a given skill is. Just saying, who's done this before? Any feedback from that before you even start. You may be encountering learners that have learned these skills or been taught about them from someone else 10 years ago, or when they first did EMS training and it's like imprinted in their head. Maybe some good habits, maybe some bad habits. So it helps you identify that from the start. You want to make sure that you're teaching skills that are appropriate to the scope of practice of the given environment where they are at. For example, I was doing part of a course doing EMS development work in the Caribbean, and they wanted us to do IV insertion. We were ready for that, but the Ministry of Health was like, that is not ready for prime time. We do not want EMS personnel like doing that stage at this time, maybe in the future. And so work with your stakeholders to know that what you're teaching is appropriate to their given scope of practice. If you notice in the the participant handbook, there's two different handbooks, right? Participant handbook, page 145 is where that skills section starts. It's a big block of a lot of different skills broken out by airway skills, breathing skills, circulation, disability, trauma, shock. You have a check-off list right there for the learners. So remember, someone else earlier advised printing that off separately. So that's like a separate pamphlet. So that way your learners have that to just go through the skills and you can check them off. The manual advises you can do a first, second, third pass type of system. So say, hey, when you're doing the assessment, demonstrate the skill, check off everything they did on the first pass, and then say, all right, you missed this and this, give it again, give it another go from the top. And they do it again, rinse, lather, repeat, and you got up to 3 times. And if it takes more than 3, you mark it for remediation, and you do that on a private basis to not compromise the progression of the whole course. What are some problems that maybe we've, as a group, encountered when trying to teach practical skills? Does anyone in that very crowded back table have any experience or problems that they've encountered? Okay. So it was mentioned that sometimes the models aren't high fidelity enough. That's so true. It's that trying to find that right sweet spot of where can a model get the point across to give us a skill, but yet be feasible and sustainable enough for us to be able to use as a course, but yet not too high fidelity that my learners won't know how to use it themselves, like going forward, like bringing in a super high-tech mannequin, or the higher tech, higher fidelity, higher chance it is going to break. Harder it is to transport, the more likely it's going to be a pain in the rear to get it through customs or things like that, like getting it to your course on time. So that right sweet spot. Oh, about this front table, any problems that you guys have encountered when trying to teach practical skills?
Having everyone at a different learning level.
Yeah, particularly if you're having like a course where you have physicians, EMS providers, nursing, like mixed levels of experience, maintaining that engagement throughout all of them. Yeah. Up here.
Balancing like correcting things, but also not like discouraging them.
Doing that in real time, like, oh, pause, and then, but not trying to interrupt their thought process or flow. One other thing is trying to be conscious to social barriers or social norms. Like a lot of these practical skills involve touching, like interacting with you as a facilitator. Some people may not want to like have a pelvic binder put on them or not be involved in that. May only want to work with females or men, vice versa. So things that you have to be, nuances you have to be considerate to. There are some difficult skills to teach, such as those that are like discussion-based only, like talking about malnutrition. It ends up kind of being how this could easily just be a lecture, a didactic lecture talking about malnutrition or GCS evaluation. So getting creative, there's space for you to be creative with flip books, picture-based, tabletop case scenario, very similar to like the exercise you just did to help solidify those skills. It's often hard to practice some skills without a live patient or a body to put it on. Really emphasize using yourself as the instructor. I think you can have one arm being splinted and a leg being splinted. You're providing direct feedback to both of them in real time while it's going on. And you can utilize yourself for pelvic binding or airway maneuvers. Mannequins are great, as we're blessed with to have them today. Yeah. Lack of equipment, right? Like if it doesn't come, it's held up in customs. So you're going to have a high degree of adaptability to be able to make do with what you got on the fly and to try to convey that. And you want to teach with the equipment you have available in country that's practical for their practice setting as well, but also do emphasize like the ideal situation too, because they may get there one day. If you teach them what is possible for the ideal situation, that helps advocate them and empower them for advocacy for themselves with their own country, because you're training them to be pioneers of emergency medicine in their local country. Lots of times with practical skill teaching, you have to really emphasize the skill of suspending disbelief, which is not an innate ability for learners all around the globe. A lot of people don't have experience doing simulation training or practicing, like you have to kind of assume some things, imagine a certain circumstance in your mind, and then perform the skill. People aren't as awkward, they're not innate actors or be able to role play in that way. We talked about those other things. And then this is the boring part of the talk, but the practical skills are split up by sections: airway, breathing, circulation-based skills, and there's a lot of skills. It's a big section starting on page 145. The sample schedule for the BEC course shows first 2 days like a lot of didactics, and then it's a lot of skills like blocked out. An alternative way to structure a course is you pair the relevant skills with the didactics that you've already given to give a mix of lecture-based versus tactile practical skill practice. And it will give a list of the equipment both in the facilitator guide and on these PowerPoint slides. Very much the equipment that we have here today. You're going to be going over six different clinical skill stations. It's just a list of equipment. But to go with my own words, less talking, more doing. This is an example of some DIY from DIY simulations from other countries. This is like an IV practice, IV insertion practice. So you're going to be simulating something close to that here. Sometimes you don't have a mannequin. All he's got is a cardboard box, paper, and you're drawing a penetrating knife wound and talking about how we're going to dress and secure this wound. Using that, that's a model that could be very applicable for a lot of the different skills, be it needle decompression, open chest wound, sucking chest wound dressing. Make do with what you got. Dolls, other such things that would be more readily available. Use the space available. Sometimes all you have is the table that you're sitting at for your teaching. Not going to be blessed with stretchers, backboards, other such things. And then don't forget to have fun. This is a real chance to have fun and engage with your learners, and again, wake them up after lunch to be able to re-solidify all these things that you're trying to teach them. Questions? Pretty straightforward. All right, at each of your stations, you have, you're going to be going over a skill. And how long are we spending at each station? Precise. Do we want group? We have 2 groups back here in this back corner, yeah? All the stuff is here. We can migrate it out there. Okay. All right, guys, let's get to it.
Are you a teacher?
Wait. Sean has a presentation before you guys start.
It's okay.
Before you guys start.
Come on.
Sorry.
Did anybody make it outside?
I don't think so. They came back in.
They came back in?
So, one way to get through those dialogue steps is right. You want to teach why something's important. You want to demonstrate the clinical skill. You want to do it again, walk explaining it. You want to supervise your learner doing the skill, and then you want while explaining it, and then you want them to teach you back something. There are ways for classrooms to send out pre-course materials to demonstrate something just being done straight through. That way you can try to pick up, hoping that your learner to watch the pre-course material. You can pick up and just go right to the demonstration of while explaining. But has anyone seen this skill of making a makeshift nebulizer spacer? Okay, it's a very common one. But just to pretend like I've demonstrated it perfectly for you. And then we're going to act like I'm demonstrating while doing this. Are you able to help me out? Yeah. All right, so we got to deliver some salbutamol to someone with an acid exacerbation. They're having acute breathing problems. Very key for us to get this medication to them very quickly, but in an efficient manner. It's wrought with problems that patients actually use medication to successfully without proper training. So we're going to make a makeshift spacer using a water Coke bottle and then your salbutamol, some sort of cutting device, scissors, or if you don't have scissors, a scalpel, or a hot heat up paper clip to cut through some plastic bottles, some sort of mark that's going to mark on the plastic, and tape. That's about it. So first step would be take your MDI spacer or the MDI liver. Key step is where you can logically mess up, tape off, cover. Put that on the back end, either on the left end of the bottle or on the side. Trace out the space with the marker, and then around the end of that movie. Then cut just inside that trace line for more tighter seal. Insert space here, you can also seal it with tape. And now, okay, patient, you're about to then do this. You need to prime this for about 5 pumps, and then you can put your mouth and be able to breathe it. How I feel. Your next step being have your learner do it while the supervisor then explaining other steps. All right. Sorry about that, guys. Now you go to the Thanks.
Then we get to learn how to my experience is that relatively new. The thing is like all these very good if you go through it like But yeah, and another thing to do is for everybody to do that careful with providing then harping on the I feel like you need it. Yeah, we don't have a light bulb, so you just flow with it, so maybe like if somebody wants to All right, guys. I think we're talking about just long time. When we're alright, so today we're talking about courses that you're doing. So as we know that babies are a little bit different than adults, right? And just size. Years that you want to like consider pediatrics versus adults, the difference between them, and how that might impact how we like this. Yeah, exactly. So you have a big head. compared to the bodies. They also have like a larger input too, and this you might do in someone who is a larger adult. You might want to put in like a towel, roll up a towel, if their airway in line. I know it's in this kind of wide process, like their airway is more right. They have more answer airway as well, and take into mind when moving airways. So, another technique that you can do, which is like very so that when you just iron the it's like might open up the airway. For me, this procedure, honestly, for instance, is having a good fear. Because if you don't, as you can see, all that air is just coming. So that is not going to be able to get through the lungs. And then you have mine now, but we don't. Yes, thank you. So the technique that we can use is using the C and E. So your C is going to go on top, and your E is going to stand here right now.
Yeah, that's what I mean, right?
The lower angle of the top to help lift. And this provides the
Maybe we do like one of these. But I don't know how to.
It's about a, yeah, it's kind but it looks like. Yeah, so we'll try it again.
We'll try again later. Yeah, it's fine. It's fine.
Somebody's on the way.
Okay, got it. Thank you.
And C and E won't always work either, just because you know what I mean? Like, yeah. Yeah, exactly. This one isn't really high. So they're basically saying that when there's two more buttons, that means too slow or too fast, or it's subconscious. They're making slow, shallow, gas, speed, or breathing, and someone who is not sure. And then if that's the case, there's all your water.
Right, so it's like, and we have, this has a lot more facilitators. That one, like, four of these in lunch one. Four of these, but it's not.
Sometimes it's helpful to have one people to do this, that way one person sitting on the press, and then one person in the skill. That way I can just my one time. You can make your role like same on the side.
I'll go.
And from that, like, the middle there is out. Yeah. Like, there's no, like, it looks like it should be. Come on, embrace the East Coast.
So this is the party for the room yet. I'll let mention. My first year.
Right, I was gonna say, I have no idea how to change that. I don't know. Yeah.
Yeah.
I think, well, do you know what there's lamps or something we could bring? Like,
I can see.
thank you.
Yeah. Yeah.
Or
Yeah.
Well, it makes sense.
Yeah.
Oh. Wait a second. Let me get it in before the next break.
Exactly.
Oh, and it has lungs there. You fire that up. Because then you can look at its lungs. Or like, there's bags. Yeah. Yeah.
I know with the AV. The lights and not clearing this all. Yeah. Tomorrow as well. We didn't know way to get a fight for if you like applying or not. No, I just wanted you to know. I'm going to let the maybe a bit. Somebody else. Yes, thank you so much.
Nice. They're not. They're just nice. I mean, there's no Wait, what?
That's actually. Thank you. First year, this year, yeah. So, and that's now vice chair, yeah, and it's like, that's actually. Just like here, so not, it's not easy to see, right?
So you have
I still have to do we're talking about trying to do that again, which in 2 years, and as a like the artist always sees happening, right? But I'm not going to take a spot from someone and I see like that. Yeah. Most of for what I like to practice. It's not skills that I can do in work. But there are definitely yeah. Especially in a small space. Well, even no, they still made it like it's something where between the five and it's just timing. Everything's hard. You don't necessarily talk to them all the time. I step away to I took this in New Orleans. It's like that's more to what you not have like all should be better. Like
People freak out.
that works really well. Like 1 or 2 days, like you have to maximize the rate on breaking. Like or not coffee. That's so cool. Yeah, I don't like the one that was it's the thing, right? The one I had this morning, I got one and that one actually, like it was like a lot more that tasted like this one. This one is fine. It's just like the one downstairs, like the extraction. The thing is, I just got back to Barcelona. Right. So like the coffee is just like incredible. Really strong. And so I think my taste buds are I'm missing out with the it's like it's like
How is it?
Well, they have a 16.
But it was like nice for you. I was like, what was that? Walker's best bet. We're one.
You're like, wasn't split, but he's a one person, so like, it was perfect.
Yeah, looks like it's going great. Yeah.
It's like,
It's a long time in this room.
especially this one, it's tough. That's why it's tough.
It did seem a little bit long. Good job. Well, perhaps are you heading into your map?
No, I'm not. Hey, I'm working all my shit. Yeah.
Sue's gonna be napping. And I don't think Cynthia
Not my jam. No. So throughout Central not too many restaurants. Since I took it, we could also no, that's the yeah. So I'm like I basically always right about and then I went to Washington. Yeah, and then digitized. Like, but after the
do this. Go to the
I started off and then my boss was like, your backup plan is no, we need it now. So I basically went back and like, why the just made me finish and watched the video. Like, I just had to pay. Right. That works. Well, it was like 50 and then my so like the total amount 200 and then worse than footprint small, country that's and this is I really thought so I would try to talk to people actually. Yeah. Even a lot of I want to by yourself, really, really. But it's not weird. Right, there's penalizers. It's only like like I'm not sure like the but the different weird part is just they in terms of like they're like no we're not fancy like my mom was a kid that was a really good storyline like that was the that was when like that's when I started fellowship. Yeah, fellowship is it's that and I hate it. I started playing. So like I feel so for residents, it's more like a it's the paycheck, like yeah, but like Right, or you like. Yeah. First year. But it's just like summer before summer. Yeah, it's just like this one. Like my girl. She's one of my dads. All the stress. Maybe stress. Like we're out here. And so like it's freaked her out. And so it's something that she wanted she wanted to move in service. She was working on one of the she wanted to go like if I'm moving, I was like I had like saw like years ago. To classes, and all the restaurants were closed, closed by 10 years. And I was like fuck, like, I'm just not getting here. To pick up like a rotisserie chicken. So I was like, I need to, I'm gonna like, and so that's what I was like, put my car got broken into my business. Okay. Right next to him and we're really, yeah. She's a sociopath.
Someone else.
I hope they had a call. She got it. These things out, I got you. So my cat's out. The, yeah, Yeah, but so you can try to take a brand. I'm trying to keep track. And I would also, you can also see it. See if you're at it's like a spring. But it's apparently there's like a appetite, like you're having it's like a metabolic. It's like a it's We're just in a juice. And she's like, she just and then he stopped as well. I was like, I thought this is a great cat. Every time I asked me, like, she would just wander around with those people. Yeah, she's like, great. And so it's really like the vet partner was and like, yeah, that's the gal. Like that. It's low, but that diagnosis was like really ribs. Like he's like walking like it was just all and so the vet like checked him out and said, you got nothing. And like it was like great. How are you treating them yeah. Right. We don't get along. Yeah. No, like everything is right. I was wrong. Like I could have been like so. Okay. Okay. Because I was like, making my job like probably my time, so like separate, you know. They said that it's like so little that they push it out. So that's like the noise that we see is. So that's what, yeah, that's what they said. I don't. They're not actually listening to me. They ruined in the shoulder when I picked them up, like, and so they were like, like that's when I like, so I was like, okay, and then I woke them up and they had time like totally got me fun. The other one I wanted to, and so I went to so she is 11 now, so like one of the people trying to figure out like by the way I played a bit of that. I would just kind of talk on cheater. And so like you can see it from John. But at least that's what I did now. Yeah, and so and that's just they grow so I just don't know. Like growing, but then that was like I didn't say it. And so yeah, they were like fine or anything. They're like you know intoxication and like the perfect thing. And it's gotten way better on it was just like like it was like right. It's fairly two-story but it is like it wasn't and so like I don't know. I think like the idea of like when I get positive except on like two sides. Yeah, and like it goes to like a microchip door on the side. Yeah. So there, it's like children with joy, that's definitely like, is you have to separate. Yeah. Yeah, there's also your kids, you know, that will do a one, like basically like dispensing like cosmetics. And like tiny, but it's only. Molly, I don't want to, I don't want to. Yeah, it's one of those things. It's not for, yeah. They hope that and then she'll get something and they're like, oh, yeah, you got to. Got it then right back.
Go ahead and switch. The second to last. Go ahead and switch clockwise. Okay, go ahead Right. At the end. Oh, yes, yes. Oh, yes, there are.
Or maybe be like. I feel like I wish I could have classes. Yeah. Yeah. But I don't, I don't know. Because like every usually there's something. He's like, just like, so they go like, like, and he got chased by like, and it was just like, it was just like but that's also my cousin who goes and like, I was a child, he stood around and he was just like, I don't know what to do with this, like, what? Right, that's what it is. He's like, this is like, it's a laptop, it's like, me, like, you're just kind of like the, like, they're not really. Yeah. Right. Okay. Now we have that. They're printing state job, basically like yes. And the other word is such a like that. This is good here for you to have it. Like,
Stand up.
Ranking up the high school review.
In my math, right. That's very helpful. And whoever's still there. Whoever's done the plan. That's like a lot of it. Well, I guess that would be great. This is the free work. Like, it's also like you're throwing it at brain on paper. Because it's definitely doesn't start it. A lot of people are doing things like the student, like, a lot of people don't have here. So it's like it isn't. And then sometimes decide.
Follow directions.
I'm gonna be a photographer. Like, I'm not right.
But I'm a
I'll try it in the room. I'll try to get that. I also,
Hey guys, so as we're wrapping up, go ahead and take a 5-minute break just to go to the bathroom. Hey guys, sorry guys. Yep, hello. So 5-minute break just to go to the bathroom and finish up and wrap up, and then kind of be back here in about 5 minutes so we can continue to go on, okay? We only have a couple lectures left, hoping to wrap up about 30 minutes early, okay?
So back at 3:15.
I know. Leave it to me to like mess things up.
Should we like grab one of the people? Do we want to just grab one of the people real quickly? I'll just grab one of the people, maybe the IT people outside.
Oh wait, wrong I've fixed it.
Okay, great. Okay, awesome. Are you next?
I'm next. Let's go. Talk about the really fun topic of logistics.
Here, you want right? If you can hear my voice, raise your hand.
He's the clearest, like, third grade teaching.
Go ahead.
All right, we are going to move into the very exciting post-lunch topic of course logistics. Woo! Where are my logistics people? I'm a logistics person. Anyone else a logistics person? I'm sorry for the rest of you, but hopefully you all will become logistics people, because if you're going to teach this course, you need to know how to do the logistics side of things. So I'm Nichole Michaeli. I am a faculty at the University of Vermont, and I have taught the BC and the TOT in Kenya, Somalia, Liberia, and Jamaica. And over the course of, I think I counted 9 courses, I have learned a lot of things. So I hope to share a couple pearls with you today of things that I've learned, and I would love for anyone else who has things to chime in, because the very first course I taught was not the best. The last course I taught was also not the best. But every single time, no, it was fine. This week 2 was better, Charlotte. Week 2 was better. But every single time I learn things and I remember and I realize things, and I'm like, like next time it's going to be perfect. And it never is perfect, but it can always be a little bit better. All right, so you are going to want to reach out to whoever that local focal point is really, really early on. I say if I'm going to start a BEC course in a new place where BEC has never been taught before, I need at least 6 months of lead time. This is not something that you can turn around and do next month unless you have already have contacts in that location, you have people on the ground that can teach the course, then maybe you can do it. But ultimately, I would say at least 6 months, probably closer to a year to really get everything set up that you need. Some of the things that are challenging are going to be the certification process. And there are 2 schools of thoughts. Some people say they really want certification. That's having IFEM, AFEM, FLAME recognize your course. And some people say this is open access. I don't really care if it's accredited by them. The knowledge is important. And I usually just go with whoever my focal point is in country. I ask them what they want, and then we try to make that happen for them. But FLAME, AFEM, they're all going to need a lot of lead time to know who your instructors are, who your participants are. Make sure you have that ratio correct. What is the facilitator to participant ratio? Anyone remember? 1 to 5. So it has to be at least 1 to 5. How many max participants can you have in a course? 30. Very good. So we did teach, we pushed AFEM once and they let us teach a 40-person course. It was really hard. There were a ton of moving parts, a ton of facilitators, and I would say capping at 30 is probably better. Ideally, you're going to want to know all of your participants ahead of time so that you can notify them, you can get them that participant workbook. That book is thick, especially if they don't have a background in emergency medicine, or these concepts are very new to them. Giving someone a 200-page book and saying, we're going to read this whole thing in a week is really hard. So you can give it to them ahead of time. That's really nice for them. And then we're going to go into some of this other stuff, talk about printing, course schedules, the venue, the catering, a little bit more in detail. So, venue. I have had so many different venues that I've taught at. Some of them are great and ideal, and some of them are less ideal. Ideally, you want a really nice, large space. I prefer to have a space probably about 2 times the size of this room for a group of 30. because I want to have tables up front where they can sit in their groups for lectures. And then I want to be able to set up all my skills in the back. And that allows you to have like people doing behind the scenes work. So while lectures are going on, people are setting up skills, and then you can just move in and out of those spaces really nicely. You don't always have that. Sometimes you have to make do with what you have, and you can kind of like turn over. And I have like a little setup area off to the side where I'm getting things prepared. But think about your space. Larger is always going to be better. The other thing you need is tables. Tables and chairs, which is something that like is not, like we're all thinking about the emergency medicine side of things, like how I'm going to teach these skills, like I'm going to teach like BVM and all this stuff. Like no one's really thinking about like how many tables do I need? Do these need tablecloths? Do I have enough chairs for everyone to sit on? If you have someone that you can delegate these tasks to, it's amazing. And oftentimes a couple of people. We have a really good colleague in Kenya who did it all for us, which was incredible. But a lot of times you are trying to do this between like working in a different place, trying to get things done on the ground somewhere else. If you can delegate it up a little bit, that's helpful. You will notice things are done on PowerPoint. There are so many words on those slides, it would be really hard to teach without electricity or without good AV equipment. And so making sure that your space is set up to have a projector, be able to run a PowerPoint. You'll run into issues sometimes with electricity. So if sometimes I'll lose power in the middle of a course, I always want to be able to like be prepared to transition. So I'm like, if power goes out during lecture, I've got my skills, we pull those in, we start skills, and I'm like, we'll go back into the lecture when the power comes back on. But you're trying to fit so much stuff into 4 to 5 days that you really don't have a lot of wiggle room. And if you lose a couple hours, that's probably going to push you late, or it's going to push you into an extra day. And then transport directions to venue, make sure that everyone knows how to get there ahead of time, has a good way to get there. We've done it in various ways. Sometimes people are able to get themselves to the venue well. Sometimes we provide a little bit of money to help people get to the venue so that it's not a cash burden to them. Just things to think about. All right. There are so many different ways that you can structure your BEC. And over the course of many, many courses, I've come up with what I think works best, but that's what I think works best. And we taught a completely different version in Jamaica a couple weeks ago that worked really well too. And so I would just use the folks that you have around you. If any of you want to reach out to me, I can give you multiple different variations of schedules. But you want to come up with a schedule in advance, ideally share it with your facilitators so they know what they're teaching, share it with your participants so they know what they're getting themselves into. And make sure that everyone knows that this is a basic emergency care course, not a basic first aid course. We ran into this issue in Jamaica where I think people saw the word basic and they were like, this is going to be for the first aid. We can teach this to anyone. And this is when really having these discussions and sharing the schedule and sharing the information in advance is helpful, because you can just reiterate that this is it's for healthcare providers. Like there's no point in teaching someone to do needle decompression who doesn't have access to needles or cannulas or works in as a paramedic or an EMT or in a hospital. We taught an accountant how to do needle decompression in Jamaica, which he was very good at, incredibly good at, but doesn't really have a use for that in his daily life and his work. When you are putting the schedule together, think about any special requirements for the country. So I work in a lot of countries that are predominantly Muslim, and so I would not want to hold this over Ramadan. That would be a terrible time to put someone through this. Also, when we teach there, we want to make sure that we allot times for prayer. And so we would structure our breaks around the prayer times. And you would just work with the local counterparts, figure out what that is. We talked about that. Oh, and then catering. Catering can really throw off your course if it doesn't happen in a timely manner. And so because the way that I structure the schedule is we do lectures and then we do small groups and then we break for lunch and then we jump into skills. And if lunch isn't ready, then we just have downtime and we're trying to do skills. And so I get really strict with my caterers on the food has to be ready at this time. Sometimes you do have to be flexible, but if you give them the schedule in advance and you're like, I need food during these hours, oftentimes you can make it happen, not always. And then just making sure that the food is culturally appropriate, taking into consideration any allergies, vegans, vegetarians, etc. Any questions on that stuff? All right, so the BEC course, it's suggested for 5 days. Some people do it 4 days. Where are my Rwanda folks? Yeah. I still want to be part of one of those 4-day courses because I have never managed to get it done in even like a reasonable 5 days. We have long 5 days. And then the TOT is 1 to 2 days. I've always taught a 1-day TOT, but recently during our time in Jamaica and working with a wonderful doctor, Dr. Cruz from Belize, she gave me some suggestions, and I think I'm going to change up my TOT and make it 2 days. And the reason I think, and I would encourage you all to consider this, it's all about time and how much time people have available. But the TOT, as you've seen, a lot of it is like how to teach, how to lecture, how to perform, like talk about small groups and how to do the skills. We don't actually do, apart from like this 30-minute session, talking a lot about like how are we actually going to implement this. And so when you're teaching, like you've taken people through the 4 or 5 day course, now they're in the TOT, you're teaching them how to teach, but are you actually preparing them well enough to teach a course on their own? Because a lot of like putting on this course is not just knowing the material, it's knowing all the different components that go into putting it together. And that's where I've found that we fall short in a lot of places that we work, where I can go in with my team and we can do this. And we teach people and people have become registered trainers and master trainers, but still are not really successfully able to take that next step and that jump to like doing courses on their own. And a colleague from Belize actually spends a whole day talking to them about brainstorming, like where are we going to have this? How much is it going to cost? Let's talk about a budget, talk about where we're going to get funding for this. How are we going to get everyone together? And I think that I would encourage you to spend a lot of time working with your partners on that part of it. Because sustainability doesn't happen if we just keep dropping in and doing these over and over again. And we're getting there with Kenya. We're pushing, making the push. There are lots of different schedules available. Some of them go through where there's lectures in the morning, then small groups and skills. I like to get people up in the afternoon because it's really hard to sit after lunch and listen to someone talk about logistics or anything else. And so if people are standing and they're moving around and they're doing hands-on things, I think that they're much more likely to be engaged and not falling asleep on you. However, if you don't have, say you only have your mannequins for 2 days because you're borrowing them from the sim center at the medical school, what you could do is you could try to cover your lectures and your small groups in the first like 3 days and then do like 2 solid days of skills, which would be a really fun last 2 days. It would be a really long first 3 days, but you can be really creative with it. This is also like the traditional like 5-day model. I'm going to go through and teach 5 straight days. You don't have to do it this way. And I challenge the people I work with to think about how they would make this work in their setting. Because it's hard to get 5 days off for anyone. You have to get all your instructors off for 5 days. You have to get all of your participants off for 5 days. And if you're teaching somewhere that's somewhat rural, understaffed, that might be like everybody in the department. So how are you going to make this work when you can't pull everyone out of the department for 5 days? And so some of the things that we've come up with is teaching 1 day a week for 5 weeks. People dedicate or donate their weekend to doing this. There's also a fun hybrid course that is currently in the early stages and it's not quite ready for go time just yet. But it's the WHO online academy where you would do self-paced lectures and then get a certificate and be able to take an in-person 2-day course, which I think is going for the correct population. I think it implies and assumes that the participants have a pretty good baseline understanding of a lot of this knowledge and really just need the hands-on practice. So it would not have been appropriate in every setting that I work in. But I think for the right setting, you could put this into a weekend, slot it into a weekend, and have people trained without taking them away from their daily, weekly work. So lots of different ideas, and I would encourage you to be creative, think about this, talk with your partners, see how they want to make this happen. But I think whenever we're traveling, it's usually easiest to like go in, say I'm going to teach for a week, be on the ground for 1, 2, 3 weeks, a month, and then leave where it's harder to stretch it out for longer. The other thing that I mentioned earlier, but I'll just reiterate is, and I'm happy to talk to any of you about it, but I really like this teach like BEC TOT followed by a BEC model. So this cascade approach. If you remember the outline of how you get through to becoming a registered and a master trainer, you have to take the BEC course, you have to take a TOT, then you're provisional, and then you have to go back and teach with a master trainer. So if you're going in and you're teaching, and this is maybe the first time this has been taught in this country, and you do a BEC, you do a TOT, everyone's provisional, you leave, none of those folks can now teach independently. And so what I like to do is run a separate course the next week, bring them back while I still have my more experienced instructors. We pair them up so that you teach with a partner. So you have a provisional trainer paired with an experienced instructor, teaching the small groups together, giving the lectures together, getting a lot of like direct feedback on their teaching styles. And so then at the end of those 2 weeks, which is a lot of time to ask people off, so I haven't quite figured out how to make that work other than like getting their jobs to release them for 2 weeks straight, which is hard. But then at the end of those 2 weeks, they're registered and they could ideally, in theory, teach independently. And so just a way to create some sustainability in places where the course is being rolled out for the first time. Any thoughts, suggestions from the other instructors? Yes.
I just have a question. I was wondering if have you ever done it where you like you 2 groups, but you're kind of alternating groups, like you do day 1 for group 1, day 2 for group 2.
I
feel
have.
like sometimes that works better scheduling wise in terms of getting people off their shifts.
So not for BC, but a different course I ran. We ran like 2 days once a week for 8 weeks, and I would teach the same course like 2 days in a row and take like half the department the one day and the other half the other day, because you can't take your whole department. It's challenging. Yeah. Other thoughts from folks who have done a lot of teaching? Schedules or sustainability?
Have you done 3 days on, 1 day off, and then 2 days again, just to?
Haven't. That would be really nice.
For everybody, probably, but.
Yeah.
Yeah.
The thing about the 5-1-5 model is it's, especially if you're doing it back to back, you teach 6 days in a row, you have 1 day off, which is usually spent kind of trying to mentor the people that are going to be coming back. And then you teach another 5 days. So that is really taxing, really tiring, requires a lot of really dedicated people. But we've done it I did it in Somalia, we did it in Jamaica, and it works. It just, I think everyone's pretty exhausted by the end and wondering what they signed up for. Any other thoughts? Okay. This is just another schedule. I think this one, everything's a little bit different. The other thing that I don't think has been mentioned anywhere, but I will mention it now, is there were these practical case scenarios that were recently developed and added to the BEC. There's no official guidelines on how many are supposed to be taught or when they're supposed to be taught. They're nice. They're sim cases that you can run with minimal materials. We usually have either a participant or a facilitator pretend to be a patient, and we call one of the groups up to run the case and take them through attention pneumothorax or an asthma case. I think there's an abdominal trauma case. And I find that those are nice. We've done them both at the end of days. I also will, in Jamaica, we started doing them at the beginning of the day. And so we would encourage everyone to come early. Instead of doing the review of the quick cards, we would run a case that applied to the material from the day before. And that's a nice way. But as you can see, the schedules are already really full. Usually we're going from like 8:30 in the morning until 4:30, 5 o'clock at night. And so there's not a lot of wiggle room. Oftentimes that's also with a 45-minute lunch, which is not ideal. Lots and lots of things. All right. Moving on to equipment and things that you need. So you need some equipment to teach your skills. I think when you guys came around to the skills group, I said I'm a trash collector when I teach these courses, and I will be gathering all the cardboard boxes and the plastic and just like random bits of pieces of things, and have all of my instructors and also participants will start giving me their trash and be like, what can you make out of this? And I have made chests out of them. So take cardboard box, cut out some ribs, put some piece of material over it, where they can feel the ribs without seeing them. You can roll up cardboard and make limbs where you can do wound packing. I encourage you to be creative when you are getting your equipment. There's some things that you just need, and I mentioned it to a lot of groups, but for those I did not, Laerdal, and I'm not sponsored by them. I don't get anything from them, but I think they did a really nice thing. They are a mannequin company, I think based out of somewhere Northern Europe, maybe Norway. They developed a subsidized BEC trainer kit that has an adult mannequin, a child mannequin, a needle decompression chest, some moulage, a lot of things that you need for $450. We looked it up, which is a really good price. So if you can work that into a budget when you're budgeting for BECs, maybe get one or two of those, leave them in country. It also comes in a backpack that you can carry on. So it was really nice. We had some questions going through the scanner with the body show up. And then there are medical supplies that you're just not going to be able to improvise. You cannot, I guess you could do a Nalgene straw as a, an NPA. Not that I would encourage that. So there are things that you're just going to need to find. We have done it both ways, where I will source things from the US most of the time because that's where I'm at and that's easier. But I've really made the push to try to start sourcing things from the country in which we're teaching the course, just so you can make sure that it's stuff that's readily available. One time we brought these really nice IV, retractable IVs, which were just the ones that we were using at our hospital in the US. And then everyone did not know how to use them and was accidentally retracting them and had never seen the retractable ones. And so it's better to let them practice with the things that are actually available rather than introducing things that are completely different or new. And then there are checklists so you can make sure you have all the supplies. I also find it nice to, and you'll see in a lot of the stations, you had enough supplies to practice maybe 2 at a time. And you have really little time for all of the skills. My schedule usually allots 20 minutes per skill station, and there are 5 people in that group. So you can think today, we had one group of 6. Most of you were groups of 4, but 20 minutes to get everyone to go through and teach something that they may have, or to practice something that they may have never done before. And so if you can have enough supplies where you can run 2 or 3 stations simultaneously and just be supervising everyone practicing at the same time, that's going to allow you to save a lot of time. If you only have one thing, you can do it, but it's just going to take that much longer because everyone has to circle through and use that same supplies. Any thoughts on supplies or running stations? Yes.
Well, I saw it successful, and we really kept the hammer on us of having a time czar. We'll talk about this.
Yeah.
Kind of here, but having we had these cards, it was 15 minutes, and I first for the speakers, because everyone can speak at different paces, and but also to keep the speakers on time, but also having someone that goes around to the groups and gives them a warning and then a final. Otherwise, if you don't those afternoons just will extend forever. So you gotta have something that's really.
Yeah. And you want everyone to get the hands-on time, but the day could easily go to 6 or 7 o'clock, and then people still need to do their workbook questions and their vocab terms and study and read the next chapter. And a lot of times we find that people that are in my course during the day are working overnight. Not infrequently, like that happens all the time. And so making sure that you maybe give them a little bit of try to like keep on time so that they can get home, get a nap in before they go and work their shifts.
The tea break is also very important.
Yes.
It is one of the things, if you try doing an afternoon session without a tea break in the middle of it, you will end up having a revolt.
Yeah, tea, coffee, gets everyone going a little bit. We did find in one of the places that we taught that they actually wanted to wait until like take tea on their way out and just like power through everything, which was the first time I'd ever experienced that. That was in Kenya when we taught this last time. But they would stay around and they would work on their workbook questions and have their tea then. Printing. So there is a lot of printing involved in this course. I have never taught with just providing PDFs to folks. WHO guidelines want them to fill out the workbook, and I think I've tried to do it in PDF and it crashes, so I haven't found a good way where you can actually do that in PDF. So we print workbooks for everyone. It's about 240 pages, I think, so it's a lot of paper. So just think about how you want to get those to the place that you're going to be teaching. I have transported them from the US. We've also had them printed in country. We just need to find a place in advance that can handle that amount of printing. There's also tests and surveys, and there's a whole printing guidelines so that you can make sure you have enough of everything. And then certificates, you might need to get those printed at a better facility than where you're getting your general stuff printed, just because certificates are really important most places that I work, and they need to look super nice. And so making sure that you can not have them smeared, which was my breaking point once in Kenya. Yes. Not that I'm aware of. We've always printed them and had them bound in country and or in the US somewhere. But, all right, and then lastly, there is this big logistics planner that we will distribute to all of you in the package of things that you will get on how to plan this course. But it basically takes you through and allows you to sign people up or have people signed up for every little thing. So for the skills, for the lectures, for the TOT. I've found that asking people what they want to teach is maybe not the best and easiest because people often will not have a preference. So I just assign people. That's been my motto or my model for the last many courses. And then if they don't like what they're teaching, I'm like, just trade with someone else. But then it becomes a less of a you problem. I give everyone their skills in advance so that they can read that section, they know their talking points, they can prepare for that. And we do it similar to how we've done it in this session. So you would teach the same skill. So you would teach OPA, if that's your airway skill, 6 times. And you get really good by the 6th time. You could do it differently. You could run everyone through, but I find that that's the best use of time. So you have 20 minutes at a station and then you rotate and everyone rotates through. Assigning people to take care of transport and scheduling and catering and equipment will be helpful so you're not the only person doing it. And Rmaah did a really good, nice job and the whole team of creating everything that you see here today. There are many, many people working behind the scenes to get this all done for you. And then this takes you through like the scheduling, or sorry, the printing and the data capture, the certificates. And you can just assign a person to each one of these things. That could be their focus. There are equipment checklists of how many things minimum you need. Every one of us, I'm sure, has a little bit of a different equipment checklist and what they think are the minimum things. I like to have a lot of mannequins. Like I would prefer to have at least 6 adult mannequins, mostly because I like to have enough where we're running multiple stations, can have 2 mannequins so people are practicing simultaneously. But you can run it with pretty minimal supplies. I think this says you can run it with a minimum of 1 adult mannequin, but then if you can find more, that would be ideal. And then this is the master printing checklist, which will make sure that you have enough sheets of everything printed, enough books and tests, because the worst thing is to like be handing out pre-tests and realize that you're like too short. I also have never done the pre-tests or the post-tests in the like Google form or REDCap, but I know that some of my colleagues have, and it works really well for them and saves them a lot of time and data entry. And so that's also a way that you could do that. But all of these lists are available in this big Excel spreadsheet. All right, and then the last thing, which I don't think was mentioned anywhere else, so we'll talk a little bit about this, is your daily faculty facilitator meeting. So we usually spend about 30 minutes to an hour, depending on how many issues we're having with the course, talking about what went well, what didn't go so well, and how we can make changes on a day-to-day so that each day can continue to get better over the course of our week. All right. From the facilitators out there, did I miss anything? Any other notes? Okay, any questions on logistics and planning? So just emphasize this is the hard part because y'all know the medicine. Yes.
Where do you own these checklists?
They are in this Excel spreadsheet, and I think we'll be sharing. Is there a folder full of stuff with them, Rmaah, with all the checklists and the workbooks?
We can try to send them out to you guys. We're sending out a lot of different resources to you guys in terms of just what we have. But if you also have one that you use as well, I would love to have that.
I have a compiled folder that's everything you need to run a BEC. So happy to share that with you.
Yes.
And yes.
Do you recommended times for different lectures and things tend to be pretty accurate, or there's some that are way shorter and others that are way longer?
With the schedule that I've honed over time, there are certain lectures that are shorter, like the difficulty in breathing lecture is shorter. The altered mental status lecture is a shorter lecture. The trauma lecture is notoriously very, very long. And so all my lectures are timed differently depending on how long I know from experience they take. I also ask my facilitators to practice their lecture in advance and tell me if they're going to need more time, because I am the time czar during courses. And I was like, if you have 2 hours, you have 2 hours. And I do not want you going over, because if you go over, then everything gets thrown off. And so just encouraging facilitators to practice. And then if they are going to need more time, then just work that into the schedule. But it's better to work it in before rather than after, during. Other thoughts, questions?
How many faculty total do you prefer?
Mhm.
What is the minimum?
So you need at least one faculty member for every 5 people. And so if your max course is 30, you would need 6 faculty to teach 30 people. In Jamaica, we had I was the course director, so I wasn't actually teaching. I was just overseeing more of the logistics and the background stuff. And then we had 6 instructors. And that works really nice. That's like ideal. We've taught a course where we had 10 faculty and 30 participants, and then you just have extra people, which are nice, doing a lot of extra things in the background. Yeah. But 6 is the minimum for a 30-person course for accreditation. All right. Oh, yes.
We talked about, like, can you talk a little bit more about the process of accreditation? Like, what you go on the website to get this done?
Sure. So just very briefly, because I know my time is up. It's different depending on where you're teaching. So I primarily work on the African continent, and AFM has a really nice accreditation process where you can email them, and they have a form that they'll send you, and they have a whole spreadsheet, and you fill out the form and you tell them where you're going to teach, attach a letter from the sponsoring organization, how many people you're teaching, the names of your trainers, the level of accreditation or certification of your trainers. That does not exist with FLAME, the Latin American Federation of EM. Although I just adapted the AFM form and gave that to them after our most recent course. So it's different depending on where you're at. And it might just be an email to the organization. They might want a larger form, but I would say starting out by just emailing them several months, ideally, in advance to let them know what you're thinking about, what you're planning, so that you can make sure you have all that paperwork in time.
So at the start, you said sometimes you go through FLAME, sometimes you just teach the knowledge state. Do you still give out full certificates if you're just doing knowledge state? So what's the difference then of teaching or something if you're still getting full certificates and they can still teach?
Right. So, yeah. The difference is
if it's an accredited course, their name will go into a database that's held by AFEM or FLAME or IFEM. And then those people, when other courses want instructors who are accredited, because to accredit the course, the instructors have to all have been certified. And so if my partner wants an accredited course, I will only select certified instructors because I need to make sure that they went through the official process. The certificates, everyone gets a certificate, and we didn't go into detail on that, but there are certificates of completion and certificates of attendance. So if you pass, you get a completion with a number if it's an accredited course that goes on the bottom. FLAME doesn't actually give out numbers. Every region is a little bit different, but the difference would be going into a regionally or international database of accredited certified instructors versus being someone who's not in that database, who there then might be some questions about bringing them into an accredited course in the future. And so that's why a lot of my partners want the accreditation so that they can continue to teach courses that can go up for accreditation.
I was just going to add to that. Sometimes people leave courses just for content delivery.
Yeah.
So if you're just going to be the course for content delivery, you're not any trainers, press things down because it's an open access course and it doesn't really matter for accreditation.
Yeah.
If you're trying to, do these models with trainers or again being a certified course, that's right.
So the content is all the same. It's just whether or not the partners you're working with value that accreditation or they don't. And I think different goals. Yeah.
Just for here in the US, if anyone's interested or wanting to plan a PEC or a TOT, please just talk to me afterwards because the entire process for accrediting a course in the US is changing. So we just
Yeah.
That's a very different conversation.
I know. I don't even get into that one. Yeah.
Can I just ask a question for the room? Because a lot of people did ask about how do you know when BEC courses are happening for those of us who are getting their BEC TOT certificates today but would like to move on within the BEC system? How do we find classes?
So there's actually a database that we made with basically all facilitators and people who completed just the TOT as well. And we actually have a WhatsApp group that we went live with a couple of months ago, where we have both participants and people looking for courses to progress their facilitation, and also people who are actively trying to teach these courses who are looking for more facilitators. So the goal is to usually just use that WhatsApp to communicate and get everyone to facilitator status, essentially. So I will be sending out the email with the link to the database sign up, and then also the WhatsApp. Please just fill out the database before you join the WhatsApp, just so we can track your certificate and everything.
And I think that a role that we might have, primarily being from a high income setting, is if you're interested in going and participating in one of these courses, I always make sure that I'm not taking a spot from someone in country. But I know AFEM is flexible with me a little bit and will let me add 1 or 2 people from the US to a course. So we're training 31 or 32 and they're just sort of an extra person there. But I also think that coming from institutions where you can get small amounts of grant money or something, that's something you could contribute to those courses. To say, I have $2,000 of grant money and maybe I can buy some trainer kit, mannequin kits or something that I can contribute as a way of thanking you for letting me be part of that course. So I just encourage you to think about how you can also give back to those places that would be hosting you for that course. All right, I'm sorry, way over. The time does not apply to me.
We're not taking a break, right?
No break. No.
Great.
You took our break earlier.
Yeah. It's fine. Mine is really easy and super riveting, so we'll go through it really quickly. I'm Oluyinka. I'm a second-year fellow at GW, for those who don't know me. And we talked a little bit about all the resources. You're going to get this little folder of all the checklists and all these things.
This is a little bit about other resources and other things. Manual and slides, as you guys I'm sure have gotten a PDF for. This is also a scan link that is available on the WHO website, I think. There are a couple other things. So there's a mobile app. I will be very forthcoming and say it kind of sucks bandwidth-wise, and it's hard to use in certain places, but it does have all the kind of components of the BEC course, specifically like the ABCD assessment, the summaries, the quick skill cards, all those things that we've talked about all day today. There also is the WHO Academy, which has just kind of gone live in the last, I don't know, 6 to 8 months, I would say. And that's part of the hybrid course that Nichole was talking about, but it is also open access, so anybody can kind of just go through it. And it has basically the whole BEC course online as well. So this is a separate thing, which is the mobile app, which has very specific, like the quick cards, all those things. And then there's WHO Academy, which is like a little bit of a fuller course. Both open access, equally available. You can use this one. You don't get like a certification or anything like that. It's really just content delivery. And then the other content delivery thing, this has a lot of cases, basicemergencycare.org. This is the password. It just has cases. So kind of like the cases that we went through today, as well as some additional cases, they're there just for additional learning tools. This, again, does not have a certificate associated with it, but is just another tool to use. Some of these cases are also incorporated into the WHO Academy, WHO Academy. I get in trouble for saying WHO. WHO Academy, and so it's both there, and then this is another one. Everybody take a picture. Another really important thing, I think, when delivering this course is showcasing, as you guys have seen today, a lot of the skills is showcasing, case-based discussions are showcasing. So another tool that there are a lot of videos, and the videos can be like the skills with the tension pneumothorax, other DIY things, or just showing basic emergency care in general. So this is another tool that has all the videos. And again, WHO Academy has a different set of videos as well, probably some overlap. And then most importantly, I hope we have emphasized this enough, your local stakeholders, your local faculty, your local resources, they're key to any delivery of this course. Without them, you probably will not succeed, and you need to have local people. And one of the goals for that also is mentorship. So not only do you want to have mentorship for the people that are there, but those people that are your facilitators, your provisional instructors, they will be there long-term to help whoever's there that's working there, and hopefully cascade that out. So can't emphasize this enough, but local mentorship is very key to any success of BEC course. I told you mine is really short and sweet, so any questions?
Can you send those slides to the?
Yes, Rmaah, we are sending these slides, yes. As well as like the link for the WHO Academy. It's actually, you can Google it, it's pretty easy to find, but those basically have everything. Questions? Home stretch. I think we have one last lecture. Amazing. So,
all right, everybody. This is the last lecture. I am the last lecturer of today. My name is Maham. I am a Baylor faculty, global EM, and previously trained at Penn. So I have most of my experience with the BEC courses in Pakistan. But also in Baylor, we run courses in Belize as well. So if you have any questions about that, I'm here as a resource to you. But without further ado, we have our last lecture of today, and that is about what else does the WHO have to offer. We have this emergency care course, the basic emergency care course, but we also have other things in our toolbox that the WHO provides. And this serves as just for you to be aware of what else there is to provide to your local champions and to be as a resource for the countries that you teach in. So this is a good overview of all the resources that are available. So today we spent a lot of time talking about the basic emergency care course, but in addition to that, we have integrated triage tools. We have standardized clinical forms for like documentation. We have checklists. So checklists for like trauma, A, B, C, D, E, the same types of checklists that we have in the course itself. We have resuscitation area designation to help deliver optimized care for sick patients and triage them to a place that is more well-resourced. And so these are some of the resources that basically over the next couple of slides we're going to talk about. So other tools we want to talk about is the Emergency Care Systems Framework. There's a picture coming up in a couple of slides that basically depicts that very well. I love that picture. I'm sure everybody here has seen it a bunch of times, but if not, we will introduce it today. There's also assessment for that, and then clinical care guidance. So right now it's the basic emergency care course, but then also there's first aid responder courses and ambulance provider courses in development. Also clinical process guidance. So that's the triage tool, the clinical checklist, the forms for documentation, and also other resources such as trauma care, trauma emergency services, a lot of resources for that as well. So basically the emergency care systems framework came out of this here. And so the 72nd World Health Assembly basically wanted to come up with a way to standardize emergency care for universal health coverage. And this is what they came up with. So this is the emergency care framework. Not getting into too much detail, but this is just an overview of basically trying to give to policymakers, healthcare providers, leaders in different countries to show what a basic emergency care framework would look like, including the scene, transport facility, all the way to hospitalization and discharge. So the different elements, so you have providers, you have tools here, you have the ambulance, the provider in the ambulance, just depicting all the different parts that play in basic emergency care. Does anybody have questions about this? This is a really important framework here. And then, let's see. So this is a reiteration, but there are these toolkits for developing pre-hospital systems. I know there was somebody here who had an interest in EMS. So there is a niche here and it is being developed. So that's a very nice way to overlap different roles, including EMS and global health. Standards for QI and data, emergency care training, formal triage protocols, and access to emergency care for like a legislative toolkit. I don't know much about that. If there's somebody in the audience who does, if you have anything to share. Otherwise, I don't know much about the legislative toolkit. The emergency care toolkit, we talked about the emergency care course. This is very repetitive, but that's how the course is. So we have our checklists here, a designated resuscitation area, and a registry for trauma and emergency care. This is to help collect data in local countries in order to optimize. And we've talked about the clinical emergency care course a lot today, so I don't think we need to talk about this too much. But this is an example of some of the triage tools, just a basic red, yellow, green triage tool. And then some checklists for trauma care, for medical emergencies, and designating a resuscitation area. And this would be an example of some of the documentation forms that are provided. And like I was saying, we have tools for data collection, very simple registry for trauma and emergency care. So those are some of the other resources we have available. Does anybody have any questions? Okay. Well, without further ado, this completes the course, and it sounds like it's time for us to do a post-test and a survey, but I'll hand it over to Rmaah for closing thoughts.
Alrighty, guys. So we are at the end of the course. So congratulations on a very long, I don't know, like 8.5 hour long day, essentially. I just wanted to pass along, Naz couldn't be here. She's one of the GEMA past presidents, but she just wanted to pass along the congratulations as well. I will be sending out again a bunch of links, information, probably tonight at some point or early tomorrow morning. And so that will kind of contain all the next steps for you guys, along with the database and kind of signing up for that. You will be receiving your certificates once you pass your post test, which you have to score 75% on within the next few days as well. And your certificate number will also be on that certificate as well. Moving forward from the BEC committee, we've been putting this TOT on for now 4 years. We hope to continue to do BECs before SAEM as well. So this past week, we did a 4-day BEC at Penn, actually, and it was our first time piloting it. And we actually have a lot of people from the BEC and a lot of facilitators as well who gratefully, made it out to that as well. So hopefully in the next year as well, we'll do the exact same thing with local partners wherever, SAEM is held in Atlanta. So the post-test QR code is right over here. You guys do have to score 75% on it. You can take it either right now or later on. It's your decision. And there's also a survey here as well, which, we require that you fill out, but it is anonymous, so we can't tell who did it, but just honor, Boy Scout honor, kind of just do it. Before you guys do the post-test, I would like to take a picture with everyone so we don't forget. Okay. So if everyone can just if everyone's okay with it, if we can come maybe over here and everyone get in the picture, and then you guys can do your post test. All right, perfect.